clouds there over these big rural, it's not rural, it's town areas. And, but at the same time, this Norilsk is actually not a big city, but it is in the northern part of Russia, and it's a big industrial point, huge plants in the middle of nowhere, actually, nothing around. And another is Siberian fires. And if to compare the effects of aerosols and on clouds and also greenhouse gases, then the main difference is also that the greenhouse gases effect is global, but these aerosol effects are mostly very, very local. And therefore, it's to understand how big are actually the global effects from this kind of physical phenomenon or physical processes, it takes time to really to count for them. And there down are written two references. But that's not all. While we were looking for this kind of bright clouds close to industrial sites, we found also another phenomenon, that sometimes close to these places there was snow at ground, just like a plume, what could be followed downwind from that plant or some kind of factory. And we call them snow mills or snow factories, which are also natural experiments. It's just one satellite image from MODIS, and you see that this white area is actually snow on the ground. But not only, the snow is not only in the ground, but we can follow it also from ground-based radars, precipitation radars. There is also, you see this factory, and you see that out of there comes this bloom of red and yellow, which means that a bloom of snow actually comes out. It's not always there, it's quite rarely there, but it is there. And we have published this kind of events about a year ago, a paper in Science, what was collaboration also with Canadian and Finnish scientists, because this hotspot is actually in Canada. We could use radars, and it was certainly a powerful experiment, natural experiments to that. But you see that, yes, the snow is there. And what is the process? You certainly know the process of Wegener-Finzane-Bergeron or ice crystal process, that the ice nucleating particles can initiate the primary ice production, but the clouds should be mixed phase clouds. About these natural experiments, what I am speaking, these are mostly all mixed phase clouds and quite low clouds. And it means actually that these ice crystals grow at the expense of supercooled droplets. Mixed cloud means that there are supercooled droplets and ice particles at the same time. And therefore, it's possible to this type of precipitation formation. And then really these ice crystals could grow as big that they fall down and give this kind of snow. The snow is not very big, as you saw from the ground, but there are two more effects, or at least one more effect. Here we see also two satellite images. The upper one is so-called cloud phase product from what is put together from different wavelengths measured from satellites, and it shows this orange plume shows actually that there is this glaciation of supercooled clouds, as well as it could be later when these clouds have fallen down that we do have a hole inside of clouds, and we can see through it actually the ground. So there is also effect of decreased cloud cover. So there are together so many effects. You can certainly ask how many events we've followed, and actually there were hundreds of them. I see just it's still this reference to the science paper that it's the map of these events, and there are really tens or more than 100 glaciation events, and you see that they are mostly in northern high latitudes. There were also some which were no glaciation events, and some of them we could follow with all this instrumentation that is available. It means with radar, with from the ground images, and also from the geostationary satellite images as well. So this geostationary satellite actually gives here a huge advantage. And the last experiment, it's not our experiment, but it's a very well-known experiment, that it's also connected to these ship tracks. And you certainly know that the International Marine Organization has put a cap, or sulfur cap, since 2020. And these are the ship tracks anomaly for 2020. And you can see that in this last history, it was certainly one of the years with less or least amount of ship tracks. But there are also, we should always look also what were the conditions in 2020. That it was COVID time, actually, and therefore maybe the trade was a little bit less during these times. But certainly there is also this effect of this sulfur gap. Yeah. So, conclusions. We certainly want to keep the global warming inside 1.5 or at least 2 degrees compared to the pre-industrial time. And of course, this needs huge reductions in greenhouse gas emissions. From this other side, at the same time, when we reduce these greenhouse gases, we actually reduce also aerosols. But the aerosols' main physical role was to cool the climate. It means that at the time when we reduce the greenhouse gases amounts, we reduce also the aerosols, and from that side it comes out that removing aerosols is actually warming of climate. But of course the cleaning of air saves millions of lives, and certainly there will be several presentations also in this conference about it, I guess. But nevertheless, cleaning up aerosols from the atmosphere and making the air quality better is very, very important issue, and we have to work more out the possibilities to better understand the role of aerosols in cooling the climate. But I wouldn't suggest maybe to geoengineer here. Yes, thank you.
Thanks a lot, Pia. Great presentation, interesting, important work. I'll immediately invite the next speaker, Professor Antonio Gasparini. He's Professor of Biostatistics and Epidemiology at the London School of Hygiene and Tropical Medicine. Antonio is internationally recognized for his pioneering work on quantifying the health impacts of environmental stressors, particularly including heat, cold, and air pollution. He's the brain behind the distributed lag non-linear model, which is a statistical approach that is now widely used across the world to study exposure-response relationships. He leads and contributes to several major international corporations and collaborations, including the MCC, the Multi-City, Multi-Country Collaboration, a very important network for studying these issues. So I leave the floor to you.
Thank you very much. And thanks, of course, to the organizers for inviting me here. So I will start from a long time ago, and just to let you know, this is not a long digression on the history of epidemiology, unfortunately, the most important topic ever. But I will start with what is considered as the first epidemiological study in the world, actually, a long time ago, just because it has all the ingredients of the aspects and topics I want to discuss today. So probably most of you know the story. This was about a physician at that time in London, John Snow, who basically identified the source of the cholera outbreak that happened in the middle of the century. And basically, just to put it in context and understand how remarkable it was a time when the origin of cholera wasn't even known. I mean, many people thought it was miasms, coming out in a way from the sewers or something. Basically, what John Snow did, he collected data on the cholera events, cases in a particular area in central London, Soho, and he identified that the source, identified that these events were clustered around a specific pump, water, or public pump, that was in the middle of the square. And basically, through this smart collection of the data, which is, again, quite remarkable considering the time, and a very nice, well-planned study and research hypothesis, he was able to trace the reason of cholera, and even more importantly, and it's a very important thing that I want to stress today, to find a solution, which is closing the pump and basically eliminating the source of cholera. Of course, fast forward 171 years, I guess. It's the problems we are facing is completely different, probably even more dramatic, if you want, because it's climate change. So our role is to find a solution to this problem, which probably will require even more efforts than just know at that time. Why is that? Is it because basically climate change affects many, many things. I will focus on the discussion today, some so-called direct effects of climate change through specific environmental stressors. We'll have a discussion today about how this problem is far greater, and it affects also, indirectly us in many different ways. Anyway, there are different environmental stressors: air pollution, extreme temperature, pollen, many other stressors. It's already established in the epidemiological literature. All of them are big factors, big risk factors for health. But of course, our role is to study. And nowadays we have new opportunities for doing that, especially considering the tools that John Snow had, a long time ago. So we have, about just focusing on data collection. Global reanalysis and projections, data set mapping the whole world, and even considering the previous talk, giving us a clear picture about what are the exposures to these risk factors around the world. Remote sensing instruments in satellite that, do the same thing, but, they cover the world and they give us a snapshot of measurements at a global scale. And of course, there are also other technologies closer, basically, to us, which is smartphone and other things that through which we can do a real-time collection of data with accurate geolocation at the individual level. Now, this setting is amazing, and especially the last part, which is about these new technologies, they open up incredible opportunities for epidemiological analysis on the impact of climate change. Now, in order to give you an overview, I selected a few case studies. I acknowledged immediately that all of them are drawn, let's say, from work we are doing in our team at London School of Hygiene and Tropical Medicine. I mean, we are really, really good, but of course we should acknowledge that there are other people doing cool things around the world, and of course this is not, it's a quite subjective view on these kind of things, but I hope it will be insightful. Now, I start with the first case study, which is a European-wide health impact assessment on the health impact of heat and cold, let's say non-optimal temperature in Europe. What are the methodological aspects of this? First of all, we're good to collect many data from many urban areas, but of course we couldn't get data from everywhere. And of course, we want to run studies that give a representative overview about, in this case, the urban population in Europe. Second, age differentials, effects of temperature change by age, and also there's a completely demographic difference in demographic compositions of populations across Europe. Second, in terms of impact in the future, there is this debate still nowadays about the so-called net effect, basically reduction in cold-related mortality versus increase in heat-related mortality, and also what is the role of adaptation. Now, all this work is being led mostly by Pierre Masselot, my colleague at the London School, and I acknowledge it, that is mostly about the work he's leading. Now, probably, I don't know, my therapist agreed that I should put some algebra in all the presentation I give, so I did it. So here, I don't want to go through all of this. It's just to give you an idea that this is based on an extension of methods that has required quite a lot of methodological work. And basically, the idea is to run this multi-stage design in which you have analysis of city level, meta-analysis of all of these, understanding of patterns in a way of deviations in what we expect being the effect of heat or cold across Europe, and the most important methodological aspects of here in which I'm focusing is this idea of spatialization and extrapolation of the risk, through which it's possible to map the whole Europe. So there's no time, unfortunately, to go through all these very interesting, statistical and study design topics, but basically what I want to focus on is the fact that probably for the first time we're able not to run the impact assessment on the locations we were collecting, but also to spatialize this risk across the whole Europe, understanding what are local deviations in what you expect being the effect of cold and heat, once we understand the role of specific, what we call effect modifiers or characteristics of the area heightening or reducing the effects of heat and cold. Now, the modeling is very complex, but basically what you get eventually is something very nice and very easy to interpret, which is a full map of excess mortality reported as standardized excess death rate, so accounting for age difference, and actually you can get age-specific effects in this place, showing how the effect of cold and heat changes quite dramatically, I would say, across Europe, with the effect of cold being more prevalent, let's say, in north of Europe, but especially in Eastern Europe, while the effect of heat being very strong in the southern part of Europe, as well, again, in the eastern part. And in all of these, you see also, not just in the big regional pictures, but also locally, that there are important differences between cities that are mostly dependent on specific characteristics of the location, which can be, socioeconomic, climatological, etc. Now, once we have this kind of information, which is basically represented by exposure-response relationships between temperature, both heat and cold, and mortality, we can also do some projections in the future. And I think this is a second study which was quite important because it helps, I would say, debunking this argument that has been put forward about how cold-related mortality is at the moment much more important in terms of impact compared to heat. And therefore, we should expect that in a way in the future, reduction in cold-related mortality will completely offset the increase in heat-related mortality. This study focused on this, and it proved that actually in Europe it's not true. There are geographical differences. This is a bit true, for example, very cold place in Northern Europe, but most of the picture shows how this net effect, which is the difference between changing cold-related mortality, a reduction, and changing heat-related mortality, an increase, is actually positive, even under very mild climate projections. In this case, 1.5 degrees. We have discussed it earlier, and it will be even more dramatic under more extreme changes. Now, this slide is about the role of adaptation. Pierre has a very nice talk on the first oral presentation, so I will not focus that much, but the idea is that we need to have a very, very, very high level of adaptation in order to prevent this positive net effect to occur. So also the second message, which is, well, we will adapt. The message is we need to adapt very, very, very heavily in order to prevent increases in mortality due to this. Now, the second case study is about small area mapping. Basically, the idea is that, okay, we have this big picture about the health effects across Europe, but what happens locally? So the idea is to run this analysis just in the UK, defining small area risks, characterizing the association, and especially differential vulnerability, depending on the very local, in this case, conditions across almost 35,000 small areas across the UK. In this analysis, we did something novel. Basically, instead than accounting just for a few, we collected information for a long list of characteristics of the area at the very small scale. We go from demographic, socioeconomic, health, and housing, let's say, another contextual characteristics, just like landscape or climatology, in order to define differences across this. And what we did, we combined all these differences through principal components into few what we call vulnerability indicators. Basically, they are kind of variables explaining differences across places, but explain difference in terms of, let's say, multivariate changes in all these patterns of characteristics across the areas. And these allowed us to obtain a very fine scale map of the risks. In this case, I'm just focusing on the heat-related part, showing that there are big differences in the heat-related mortality across England and Wales on the left, in particular connected to urban areas, we should say. But even if you go to London, and in particular a specific borough of London, I mean, specific location, we can see big differences also at the very small scale, and not unexpectedly, the lower risk area, let's say low impact area in the north is connected to an area where there is a park, a region park, and also is a wealthier area, and therefore we suspect there are characteristics of that area that are helping reducing the impact of heat in this case. Now, another case study is about the use of spatial temporal machine learning models to reconstruct exposures. Now, this is an active area of research. Many teams around the world are contributing. Basically, the idea is that you want to apply these novel models, and especially cutting-edge machine learning algorithms and the continuous evolution of algorithms in this case. We apply GIS and spatial temporal harmonization to derive big data sets of information, and we want, in the latest studies, to increase the resolution as much as possible to be able to define exactly what are the exposures at the very local scale. So what we did, and this is the work led by Arturo Cruz-Libardi in our team at the LSHTM, we collected information on many spatial and spatial temporal predictors. We used them to train specific machine learning algorithms, and then we are able, through this algorithm, to specialize basically the risk, and we derive maps at a 1 kilometer grid, and this is a a snapshot of 3 specific days, daily level of effects of levels of PM2.5, fine particulate matters, across the whole UK, and actually with a focus on London. Now, what we are doing recently, and is still unpublished, it tried to extend this, because if you look at the big picture, it looks like a very fine resolution. But if you go again in the borough of Camden, it's a local place in London, you can see that this 1 kilometer scale can struggle to capture local differences. So what we are doing, we are moving from a grid to a pointwise model in which we are able to assign local, very local measurements and to train the model on a finer scale. And therefore, we can see that from the 1 kilometer grid, we can obtain finer scale, 10 meters level predictions that maps also sources of pollution up to roads, etc. So we are able to assign exposures at a much finer scale. Now, what we do with this? We have all this information about exposures, and at this point, we want to move further, meaning all these analyses done at a global scale, etc., small area, very interesting, but we want to start on analyzing effects at the individual level, especially to analyze the individual level risk and susceptibility in population, and possibly etiological mechanisms on many environmental stressors. So we are at the moment linking all this wealth of exposure information to many cohort platforms in the UK. Of course, other people are doing that in Europe or many other places in the world. And the idea is to run novel study designs and type of analysis assessing individual susceptibility. And our former colleague Jacopo Vanoli did a PhD with us and has started all these analysis. The idea is that we are operating now in cohort data platforms through which it's possible to do all these linkages. And the idea is to bridge the gaps between these two worlds, in one in which we have this geospatial environmental modeling that I explained earlier, and the other is this amazing health data infrastructure through which we can connect information at the individual level, not just on health events, but also on characteristics just like, genetics, metabolics, and behavioral factors. And if you connect all of these, you end up reconstructing individual longitudinal profiles in which you can map exposures in time across individuals, but also different health events and also different profiles of each individuals, as again, going from clinical to genetics or medication, socioeconomic information. So the idea is that we can use all of this to recreate exposure histories and fine-scale study designs in which you can look both in the short term or in the long terms, what are the impact of these environmental factors. Now, final case studies is about real-time monitoring devices. I mentioned this at the beginning. These open up the field incredibly, because not just you can trace individuals in terms of their exposure, but also you can look at health indicators that are finer in a way, and therefore you can make use of these technologies for this. So you can reconstruct, for example, longitudinal profiles in which you match, for example, specific mild symptoms also collected through all of these with many environmental indicators. And I show a couple of examples here. First of all, a smartphone study in which we look at health effects of environmental stress, in particular on allergic reactions, and applying all the wealth of methodological developments that we have developed at a big scale, actually at a fine scale, to look at how pollen, PM2.5 and temperature affect your risk of allergic reaction. The second is actually very interesting and as in unpublished study still under review, which is heat and cold and the risk of hypoglycemia in diabetic people who are basically followed through these glucose monitoring devices that look at, they monitor and they help dosing you with insulin in order to keep your sugar level optimal. And this study proves that especially the effect of heat is incredible in disrupting this mechanism of the device and actually putting you at a very much higher risk of hypoglycemia, especially diabetic people. Now, final slide is about code and data repositories. I cannot stress enough how this is important. Basically, the idea is that when you do a methodological development, it's very important that other people are using it. Otherwise, it's just, showing off. And through repositories in GitHub, on Zenodo, my team and others, of course, are able to disseminate these new developments and especially make easier for others to apply these methods in many different places. And of course, I put some references and links to our environment and health modeling lab at LSHTM, where you can find articles, tutorials, web apps, etc. And I invite you maybe to have a look. Okay, thank you very much.
Thanks a lot, Antonio. Now I'd like to invite the next speaker, the last keynote speaker in this session. Please welcome Professor Rachel Lowe. She's an ICREA research professor and head of the Global Health Resilience Group at the Barcelona Supercomputing Center. And she's also a Royal Society Dorothy Hodgkin Fellow at the London School of Hygiene and Tropical Medicine. Is that right? Rachel's pioneering work bridges climate science and infection disease modeling. And she's working to enhance preparedness for climate sensitivity disease outbreaks across different parts of the world, Latin America, Caribbean, Southeast Asia, I think, maybe even more. She has served as an advisor to the Red Cross, Doctors Without Borders, and the World Meteorological Organization, and is involved in major international projects, including for the Horizon Europe and Wellcome Trust. And she also contributed to the 6th IPCC assessment report. So please, Rachel, the floor is yours.
Thank you so much. Okay, it's a pleasure to be here, and it's also to follow after Antonio. Thanks for that wonderful talk. So I'm going to share some of the research that we've been doing, trying to see how we can integrate climate and health information to provide better intelligence to be able to make decisions in terms of building resilience around climate and health, to develop climate services, and also to ensure that they can be implemented locally. We know that climate variability and climate change can impact infectious disease risk in multiple ways. So the average climate conditions define the geographical limits of the distribution of many climate-sensitive infectious diseases. For example, we know that there are several diseases transmitted by mosquitoes and other vectors that tend to be constrained in more tropical or subtropical regions or lowland areas. And also, these climate conditions can define the seasonality of different diseases. But we're seeing with anthropogenic climate change that the traditional geographical barriers to the transmission of many diseases have been eroded. And we're starting to see mosquito-borne diseases and diseases transmitted by other vectors shifting to higher latitudes, for example, in Europe, or into southern parts of South America. We're seeing more instances of outbreaks of diseases like dengue and malaria in highland areas. And we're also starting to see a change in the seasonality of many diseases, where we're having longer transmission seasons, or we're seeing extended peaks where conditions may be too hot in certain parts of the year, and the distribution of the disease may extend to other seasons. And this poses a huge challenge for public health decision makers who need to implement timely control plans and be ready for the emergence of new pathogens. So we've been working to see how we can integrate different types of climate information into decision support tools to help understand these evolving risks and see how this information can help provide timely information. So we work with data to represent observations about the climate, which may be from ground stations or from satellites or from reanalyses products. And we use this information to develop either indicators for collaboration, such as the Lancet Countdown, or to formulate statistical models to understand historic associations between changing weather patterns and disease outbreaks. And then we can also use weather forecasts or climate predictions to help us make short-term early warnings from several weeks to months to years in advance. Or we can use longer-term projections about how the climate conditions may evolve given different decisions that may be taken by policymakers in terms of the amounts of greenhouse gas emissions that we allow our countries to pump into the atmosphere, or the different socioeconomic pathways which we may take. So at the Global Health Resilience Group that I lead at the Barcelona Supercomputing Centre, we're working with partners across the globe, both international researchers, ministries of health, environment agencies, humanitarian centres, to build these tools that are driven by different types of climate and environmental information to help build local resilience to the threats of emerging diseases and epidemic potential. So we're working with many partners in Latin America and the Caribbean, in Europe, in parts of Africa, particularly through our partnerships with Médecins Sans Frontières and Red Cross, and also in parts of Asia. And we're working towards building different kinds of tools to address questions around improved preparedness and response to outbreaks of infectious diseases, or to help guide adaptation planning. Also to be able to evaluate interventions to see what may have happened in the absence of these interventions, or to help guide the distribution of loss and damage funding. So in our group, we're developing a suite of digital public goods, which are open source tools that are designed to allow different researchers and practitioners to make use of this information we've been developing over the years and be able to implement this in practice. So we have two examples here. One is the EPI Outlook platform that we're developing within the ID Alert project. And this is a tool which is designed to produce seasonal outlooks of the changing climatic suitability for different disease vectors or pathogens. And my colleague Diana Urquiza will be presenting this work in a session this afternoon, so please do join us at 3:30 to hear more about EPI Outlook. We're also, thanks to funding from the Wellcome Trust, we're working on two climate, health and digital technology initiatives called Harmonise and ID Extremes. And within this initiative, we're building a suite of R packages that can allow users to harmonise different types of data and then apply different modelling techniques to be able to produce predictions going forward. And this toolkit has been documented in the Global Goods Guidebook for Climate and Health that's recently been published by the PATH initiative. So I'll speak a little bit more about these tools as we go. So in our group, we have a fair bit of experience of working together with partners to co-create early warning systems with particular emphasis on vector-borne diseases. And in this book chapter, we publish a range of examples of our experience of engagement, the kind of methodologies you may use, and the challenges around implementation. This is an example of one of the applications of our work together with the National Environment Agency in Singapore. In Singapore, there's very high quality data sets are available describing the epidemiology of dengue and also the different serotypes of dengue, which is usually quite uncommon to have access to this kind of data. But together with changes in the climate, when you have changes in the dominant circulating serotype, this can have a huge impact on the potential magnitude of a dengue epidemic. So we've developed a modelling approach where we're integrating both different types of climate information with indicators about the switching serotypes in Singapore. And this modelling approach has been adopted within the toolkit of the National Environment Agency, and they were particularly interested in using this approach to be able to evaluate their recent intervention, their very intensive Wolbachia intervention. So they have a release of Wolbachia, which is reducing the mosquito populations in hotspots across Singapore, and to be able to try and quantify the potential impact of this Wolbachia intervention. Here the agency have used our modelling approach to simulate what the potential risk of dengue using climate and serotype information formulated using dengue cases before the intervention, and then using this to make a simulation forward of what the risk may have been in the absence of the intervention, and comparing it to the cases that were actually observed. And this led to an estimate of approximately a 28% reduction in dengue due to the intervention. We've also been using these modelling approaches to try and disentangle the different drivers of the expansion of dengue. Here we have an example of some work we've conducted with partners in Vietnam. So in a paper where we were disentangling the role of climate variation from different types of urban infrastructure and human mobility. Here we can see the temperature-driven component of the disease risk and how that has changed in the last 20 years compared to a baseline period from the 1950s to 70s. And we can see that due to the warming temperatures, we're starting to see a shift in the seasonality and an increased risk of dengue in the more higher altitude regions in the north of Vietnam, which has implications for the way that the authorities have to control the disease. So much of the work we've developed has been thanks to the partnerships that we've developed, and we've been following a very demand-driven approach where we're developing models based on the needs of our different partners. Here, this is an example of a partnership that we've developed in the Caribbean. Since 2017, we've been working with the Caribbean Institute for Meteorology and Hydrology, the Caribbean Public Health Agency, and national partners. Here, this is an example of our partnership in Barbados with the Ministry of Health and Wellness and the Meteorological Services. And this initiative has been able to evolve thanks to multiple different funding opportunities, a very strong partnership between academia and the practitioners, and very strong buy-in from the regional partners to integrate climate information into their decision planning. So through this collaboration, several years ago, together with Antonio, we developed a methodology which allowed us to integrate the distributed lag non-linear modelling approach together with our Bayesian hierarchical prediction frameworks. And this helped us identify an interesting pattern where the risk of dengue several months after very dry conditions leads to an increased risk of dengue, but also immediately after exceptionally wet conditions. So this was a very interesting finding, which was validated by our partners operating in Barbados, who were seeing this changing epidemiology given these drought events, which was likely due to the recommendation to install water storage containers given drought, which of course can lead to additional mosquito breeding sites. But when we came to try and implement this framework in practice, having all the multiple lags and leads within this kind of model framework can be quite challenging for the meteorological or climate services who have very standard products that they're issuing on a routine basis. So this was actually not a very practical framework. So we've been working together with the Caribbean Institute for Meteorology and Hydrology and with Chloe Fletcher from my team to think about how we can translate our findings from using the distributed Lagnol Niño models to try and identify which are the key hydrometeorological indicators which can lead to these interacting compound effects between drought, exceptionally wet conditions and heat. And by implementing this long short lag interaction framework, we've been able to identify very similar patterns that we found. So for example, if we look at a scenario where we have cooled conditions, then we tend not to see an increased risk of dengue, any conditions related to rainfall. Whereas if we look at a scenario where we have very warm conditions and then we have a drought followed by exceptionally wet conditions, we see this elevated risk of dengue, and we're able to account for this sequential events. So in practical terms, I'm not sure if I have a pointer, but if we're putting this into practice with our partners at the meteorological services, if we want to make a prediction of the risk of dengue 3 months in advance, then we would observe the conditions in the previous months, and if we are experiencing dry conditions and it's currently hot, and then we have a forecast suggesting wet conditions in the next month, then this modelling approach would suggest a high risk of dengue. Whereas if it was dry, it's currently cool, and the forecast are for dry conditions, then the model would indicate a low risk of dengue. So as well as developing these modelling approaches, which I'll show an application of this in a few minutes, we've also been documenting this experience, this co-learning experience, and putting together an implementation framework of how to develop a climate service for health, particularly in this Caribbean small island developing state setting. And this has also served as case studies for the World Meteorological Organization's State of Climate Services for Health, along with our work in Vietnam as well. So here's an example of some of the guiding questions that are included in our implementation framework. So not only thinking about the kind of questions you need to address to develop a modelling framework, but also how are you going to ensure buy-in from the different stakeholders, who will be in charge of monitoring and funding this early warning system going forward, what kind of graphical outputs are needed, and how are you going to communicate this information. For example, is a shiny application necessary, or would a PDF report emailed to the key decision makers every month be sufficient? Who will create and conduct monitoring and evaluation of this early warning system? Because of course, once you implement any kind of early warning system, the way you evaluate that can no longer be statistical, and you have to start monitoring other kind of metrics to address its success. And what's the return on investment, and how can you communicate that to the general public? So as well as these partnerships, a very key component has been the capacity strengthening and knowledge exchange between the different partners. Here are some examples of some training activities that we've conducted in Barbados and in Sri Lanka. So bringing together all the different partners and agents from the disease control teams, epidemiologists, medical professionals, data scientists, bringing everyone together and developing activities to ensure that we have a robust workflow that could actually be implemented in a real-time setting. And of course, to develop all these modelling approaches, you first need to take a step back and ensure you have very robust data sets to inform your model, because as we know, garbage in, garbage out. And we've been working, thanks to a Wellcome Trust funded project called Harmonise, on different approaches to be able to make this job of harmonizing data a lot easier and more straightforward. And together with Claudio Cordesso from the Oswaldo Cruz Foundation in Brazil, we published an annual review detailing a data harmonization process and protocol. So thinking about all the different components, from defining the question to conducting data audits, the process of data sharing agreements to ensure data justice and data ownership, and making sure, as Antonio said, everything is very well documented and reproducible, and iterating that approach over and over, so that we can process all these different types of data, from global reanalyses to travel data to sentinel sites and all the different types of data that you may need. And this is important because we know that many of the data sets that are openly available are actually quite limited in certain settings. If we think about the reanalyses climate products that are often used for climate and health analyses, like the ERA 5 land product, if we map that out on small islands, we can see on the left here, this is precipitation from ERA 5 land over the Dominican Republic, which is quite a large island, and here we can see some of the local orography. But if you start trying to apply these products in the very small islands like Barbados, Grenada or St. Lucia, they become very limited, and it would be much more accurate and effective to be using ground truth weather stations to inform these kind of activities. And this is just an example of a study we conducted to see what is the downscale impact of your choice of climate product on a health impact model. So if we're looking here on the left, we have an example for dengue, and on the right, we have an example for malaria. These models were formulated for southern coastal Ecuador. And we can see just one example for dengue. If we're to formulate the model using meteorological station data from a weather station located in the city, for a 1 degree increase in temperature, we would see a 68% increase in the risk of dengue, whereas if we were to use a climate product, this risk could decrease to, say, 40%. And then for malaria, we're seeing even contradictory results. So this is more of a word of warning about carefully assessing the viability of these global products in local settings. And as part of the Harmonise project, we've been working to install weather stations strategically in locations where we have data gaps. And then this can help us downscale coarser resolution data. So we can see here the blue grid in this map is the ERA 5 land resolution mapped over a hotspot. We're working in the Colombian Andes. Whereas the larger black grid, this is showing the resolution of the ECMWF seasonal climate product, which will then essentially eventually be used to inform early warnings. So as part of Harmonise, we're building with an international partnership, building different parts of this toolkit to bring together different types of data from climate, socioeconomic, land use. We also have advanced packages to work with data cubes and drones. So we're building up this toolkit. Some of our packages, GHR Explore and GHR Model, have very recently been added to CRAN. We have several users who have already started to make use of these packages, and I hope to hear from all of you, your experiences of using them. And just very quickly, I'll give some examples of how they've been applied in practice. So using the framework I shared earlier for Barbados, this modelling approach was used to produce a real-time warning ahead of the 2024 Cricket World Cup, which took place in Barbados. And a risk of high warning activated additional controls around the stadiums to ensure the breeding sites were eliminated. We've also, in the last 2 years, taken part in a dengue forecasting challenge, which was organised by the InfoDengue team in Brazil. So the goal of this challenge was to produce outlooks for the entire year for the 2025 and 2026 season. And we're pleased to see that the global health resilience modelling approaches have performed very well in both years. So we hope to be able to share more information on that as we go. And we've also been building these modelling approaches into an online platform called Endcast to produce these seasonal outlooks with our different partners. And just to finish off, we're also working on a new project called Tactic, which is led by Professor Ana Vicedo. And in this project, we're looking at ways that we can integrate these kind of toolkits or develop new ones to be able to look at integrating different types of counterfactuals or projections to be able to address different kinds of questions around health impact attribution. So I hope in the next conference we'll be able to share more details about these results and these packages. And my final slide is on the integration of different types of new information. We're working together with partners at the Barcelona Supercomputing Center to make use of the climate adaptation digital twin, which is producing very high resolution simulations about the climate, both in a pre-industrial, a current, and a 2-degree warmer world. And we're looking at integrating this kind of fine-scale data and to see how we can address storyline and event-based attribution methodologies and try and improve the resolution and quality of our climate-related decision support tools. And with that, I will finish, and I'll look forward to any questions in the panel session. Thank you.
Thanks a lot, Rachel. So I'd like to invite Pia and Antonio up to the... And we are a bit late already. We're starting with a delay, but so I'll try not to go too long into the coffee break. You will have the chance to ask some questions to the panel, but I'd just like to invite you to reflect upon when it comes to methodological questions. And actually your introduction, Rachel, was very much to the point to what I had planned to ask. I mean, there's a lot of things are happening fast now. Climate change is happening fast, but also the development of artificial intelligence, different digital technologies, machine learning has been mentioned here. So I'd just ask you, to what extent you foresee that this will change the way you will be working in the future? Is this a question kicking in open doors, perhaps? Do you see, for instance, when it comes to interdisciplinary collaboration, do you see any potential for these new technologies to be able to include more drivers of the hazards and the impacts? You already have mentioned, environmental factors and demographic, socioeconomic. There are many other factors that we can think of that actually impacts on the real sensitivity of people and whether they are damaged. So do you see any potential for further increasing the use of these tools to include more factors? As also for you, when it comes to drivers of extreme events, of the linkage between aerosols and climate, if you have any thoughts about that, I'd like you to invite you. I don't know who would like to start.
I guess some of our recent experience of developing either machine learning models or working with partners who are using them, I think it really depends on the scale of the data that's used to inform those kind of modeling approaches. So if you're working in very data-rich environments, then it can be beneficial to be able to understand and all these different drivers. But often if you're working in settings, for example, we've been working with Médecins Sans Frontières to develop modeling approaches in very small settings, trying to develop a decision support system for a clinic, then it may not be relevant to have to go to such complex methodologies, and actually a more parsimonious approach may be better. We also found this with our partnership in Singapore, that their existing modeling approaches are machine learning based. But when it came to then evaluating their intervention and wanting to understand different drivers, they opted for a more sort of traditional statistical approach so they can try and understand the different kind of drivers and their roles, because it can be difficult sometimes to unpick those when you're using, depending on different kinds of machine learning approaches. I would say that we're definitely seeing opportunities to integrate AI to improve the accessibility and usability of our products. So we're looking at using LLM approaches to develop AI assistants so that a user can more easily interrogate the kind of tools that we're developing. So they're like some of the opportunities that we're definitely seeing to bring AI into our research to make it more accessible.
Great, thanks.
Yes, the work what I showed actually was mostly manual. And this kind of through this kind of manual work, You can maybe research some 100 cases, 1,000 cases. But of course, to get the global understanding, you need actually machine learning to do it. For instance, these figures, which were the last ones, the ship tracks, the global view of ship tracks, it has been made already by the machine learning methods. And of course, it's very valuable for that. And of course, all this international collaboration, as well as using different methodologies together, it gives a very good opportunity to really go further and into deeper details. Yeah.
Thanks, Antonio.
Well, as a methodologist, I think that improvements in AI, etc., will massively change the landscape in a way or another. I think it's very difficult to say now how, because there's a lot of hype on some methods, and then we will eventually probably find out that they're not that good, or others that we haven't discovered yet that maybe will be fundamental in a few years. I think, first of all, we are already using some of them. I presented something on application of machine learning. You can consider that a kind of black box AI method that we can already use in some in some instances. I think it's important to understand that these are tools still, methods. They are significantly improving some parts if compared to existing methods, but you should use them and know how to use them. So this doesn't replace a well-planned study, good frame research question, etc. That you still need to do your homework before you use them, instead than passively getting into them in a way.
So that is actually a concern, that it might be misused or over-interpreted. And,
well, absolutely. Yeah, there is the tendency to say, well, I'll throw everything at first machine learning or their large language model tool, and it will give me the right answer anyway because it knows, let's say, but probably it's not the case anyway.
Yeah. Could it also be the case that if it's not understood what has happened, then there's less trust in the believing and actually applying the results? I mean, at the local level or national level, where they are to plan interventions, adaptation, whatever, they need to trust and understand what's going on. Have you been working with local partners? Have you had any experience with the?
Yeah, I think usually the more simple, the better, because we found that our partners really want to understand the mechanistic drivers and be able to have very clear, simple indicators to be able to track the changing risk, particularly our partners in Barbados. We just produced a very short video with them with the Pan American Health Organization, and it's just so interesting to see how the work we've done together is interpreted, and the more simple, the more it can be trusted and applied. Yeah, because if you're developing an approach that isn't informed by local knowledge, or just, as you say, like a black box approach, it's very difficult to trust it.
Sure, and I suppose we're in the start of this development. So we have a few minutes left for this session. I would like to, if there's anyone in the room here who would like to ask questions to the panel, this is your chance. So please.
Go ahead.
Yeah, I see one hand there.
Hi, thank you so much for very interesting presentations. I have a question for Pia. You were talking about snow and its potential to increase albedo and contribute to lower temperatures. Are there other pathways? I'm thinking about rain, for instance. Could that help as well, where we have increased rain due to more aerosols and through evaporation that it contributes to lower temperatures?
Yeah, the first problem always with clouds and rain and precipitation is that you have to have this humidity in the air. If you don't have it, you don't get clouds and you don't get what is further coming. Yes, in these higher latitudes, the main formation of precipitation is actually through this ice crystal process, what I showed, and I think there could be also quite a problem if already up in the atmosphere there is no so low temperatures that this kind of processes will stop, for instance. This could be a very big problem, because through this process we get also the rainfall at the ground. But of course we know that the ice is not in the clouds just at 0 degrees centigrade, but it's mostly around -40 degrees. And I don't want to say that there is so awful things happening at the moment, but physically, what happens then when it's in the way is that it's not enough cold anymore in upper levels of atmosphere. I don't know if I answered.
Thanks a lot. Yeah, one hand there, I see. And there.
Thank you. Maya Nagel from University of Haifa. Thank you all for the fascinating lectures. And my question is for Rachel. I was especially intrigued by your co-creation approach. Policy-making processes are often so messy and full of interests, very different from research. And I was wondering if you can tell more about the interaction with stakeholders. How is it conducted? Is there a methodology? And how do you follow whether the research and modeling have been implemented and whether there were actual results for the interventions? Thank you.
Thanks so much. So with our collaborations, particularly in the Caribbean, because we're working in partnership with the regional national bodies, there's always concurrence that has to be approved before any kind of collaboration starts. And then we always begin with sort of co-creation meetings, really just to understand what's the key problem, what's the kind of tool they're interested in, what are the lead times. If you want an early warning model, how much in advance do you need the forecast? Because that changes quite a lot depending on where you're working. For example, our partners at MSF have very different needs compared to mosquito control teams in other places, because often you're having to ship in medicines and get through different kinds of customs, and there are different time frames which are relevant. And because of that, we're sometimes having to develop a two-stage approach where you may have a longer lead forecast, which is a lot of uncertainty, and then as you approach the target, you can produce perhaps a more precise modeling approach when you can start or a precise outlook where you can start to incorporate the active surveillance data that's being collected. So yeah, it's very much just understanding and using the available information. Make sure you're just formulating a model with information that is available in real time, that you can keep updating your framework. Because if you formulate a model with data that's is not updated in real time, then it's not going to be any use in practice. So. Thanks.
Thanks a lot. I saw a hand over there.
Hi, thank you. This is Labib from Utrecht University. Rachel, I have a question about your modeling interventions, kind of like you're looking at forecasting. Do you think you're working on models that could be looking at multiple interventions, not just forecasting, probably cooling the city with nature-based solutions, or just giving some sort of advice on work-related exposure assessment? Like simulating in the future, like Antonio did a lot of work in simulation. Do we have simulation platform like this that could help us in different scales?
Yeah, the R packages that we're developing right now, so the GHR model package, it allows you to create space-time modeling approaches, integrating DLLMs or different kinds of long-short lag. So you can sort of use these methodologies to address different kinds of questions, and it depends. You would design your model differently depending on if you're looking at a short-time prediction compared to longer-term projections, or looking at counterfactuals, for example. So these kind of approaches can be used for scenario-based analyses, as well as kind of forward-looking probabilistic simulations. So I think it really depends on the kind of question you have, or whether these kind of toolkits or other approaches are needed to do these kind of scenario-based analyses.
Okay, thanks a lot. We can allow for one more since we were a bit late here.
Thank you. A question for Rachel and also for you, Antonio. Do you consider, or are you already integrating citizen-generated data? Like, for example, there is like the mosquito alert initiative, and there is also the use of sensors collecting air pollution data, net atmospheric temperature, and wearables.
I can just quickly say we are partnering with the Mosquito Alert initiative, particularly in ID Alert and another project we have called E4Warning. So we're hoping to be able to integrate the data that's collected through the citizen science applications to combine it with our EPI Outlook platform to help improve the precision of the kind of outlooks that we're giving about suitability for different climate-based diseases, climate-sensitive diseases. And in our Harmonized project, particularly with our partners in Peru, they are developed a platform to collate not only weather sensor data, but also to monitor air quality and different kind of indicators at this very localized scale.
I think it's a very interesting area, especially for, I mean, at least in our context for exposure modeling that I've shown, especially because you can get measurements taken in places where you have no monitors that can help the model quite a lot. And actually, within the machine learning framework that is being developed, it will be quite easy also to integrate some data that they can have some, say, lower precision or appropriateness, and also probably some kind of biases, because you can weight them or try to redress that, but they will still be fundamentally important to build, especially the specialization of the model. Actually, if you have some advice on some of these citizen science pollution monitoring in the UK, I will be thrilled to know about that. So please reach out.
Okay, thanks a lot. I think we are now heading for the coffee break or tea break. So just want to give our keynote speakers a big hand, and thanks a lot. Yeah, sorry, one more thing.
Nice. So we have internet issues, so we're waiting for your presentations to load up. So I will try to pass the time until, yes, okay. Anyway, it's really nice that this session is on adaptation, so goes to the other end of the problem, looking at solutions, which I think are way more important. Of course, the science is important, and everything we heard today in the keynote sessions, all these issues are very important, understanding the exposure sciences, relation to health and so on. But I think in the end, policymakers are desperately asking, what do we do? And I think what do we do is now, the most important question is adaptation. And I think the issue with adaptation that I have observed is that it's, on a global scale, it's easy to say you need to adapt, and you need to adapt heavily, as Antonio said. But when you come down to very local scales, the question is what works, what doesn't work, and if you have multiple exposures, it's an additional problem. You have multiple health outcomes, becomes an additional problem. You have the geography of the city. You have so many different things that influence adaptation at very local scales, aside from, of course, the socioeconomic aspects. So I think this session is really, really good, and we have a lot of interesting talks. What I will do now maybe is to just give you the titles of the talks that we're going to have in the session, and then we go over to the first speaker. Or I can introduce maybe each speaker before the session. That might be easier to go with. So our first speaker for today is Per Maslot. So Per, maybe you want to come on stage. He's going to be talking about assessing the role of adaptation to heat in projections of temperature and humidity across European cities. So I'm sure it's going to be an interesting presentation with a more wider regional framework for all of Europe. So welcome, Per, and I look forward to your talk.
Great. Okay, it seems to work. Okay, well, thank you, Shilpa. And well, arguably, this presentation will still remain at a very, let's say, high level.
Sorry, for the logistics, you all have 12 minutes. So I will start my timer now. Okay. And you have 12 minutes. The problem is we have 6 talks. If we want any discussion, you really need to stick to the 12 minutes. And I'm not very good at keeping time, but I will try to warn you beforehand if you're going over time. Okay?
It's all right. I'll do my best. Okay, and so I'm very glad that Antonio talked about this work on the European health impact assessment and adaptation that we did. So it saves me from giving a lot of background. And in this presentation, I will focus on one particular aspect of what he presented, which are the projections and how we integrated scenarios of adaptation in those. So just as a starting point, we started by doing this big health impact assessment of heat and cold related mortality in European city. And one result that has been talked about is that we estimated in our period of 2000 to 2019 an average number of heat and cold related deaths per year, so which would be around 130,000 for cold and 13,000 for heat. So we found, we counted on average around 10 times more deaths related to cold than to heat. And it's just to say that this is nothing particularly new. This is quite a common result. So we see here other studies that have found very similar results. So here it's expressed in terms of attributable fraction. But you can see that in those 3 studies that I highlight, we have roughly the same pattern of about 10 times more deaths related to cold than to heat. So the usual question that comes with that, and this is a point that I've already heard made, is so with this, this state of fact, would we expect a net decrease of mortality with a global warming? So since we have so many cold deaths, maybe with the climate warming, we will see this increase in cold-related deaths, and so we will get a net benefit in terms of direct temperature-related deaths. And so this is what we set out to estimate, using everything that we've developed in the health impact assessment in Europe, so using the exposure response function that we have developed and then using global climate, global circulation models, daily projections of temperature from many models, we tried to estimate how this would evolve in the future with global warming. And the idea here is really to isolate also the effect that climate change has, so the net effect of climate change, also from potential changes due to the demography, due to the aging of population, and so on. And so a first result that we can show are those trends at the European level. So this is covering our 854 European cities. And basically you see in red the evolution of heat-related deaths, which increases. In blue, the evolution of cold-related death, which decreases. But when we put both together, we see this net increase in overall temperature-related deaths. And of course, it's relatively mild at SSP1 scenario, but for the most pessimistic scenario, let's say of SSP3, it starts increasing quite a lot by mid-century. But then the classical next argument is, what about adaptation to heat? Because we have already good evidence that there has been some adaptation of the populations to heat in the past decades. So I can cite, for instance, Antonio's studies published 10 years ago that shows that in more recent years, the relative risk for a given temperature was lower than in the 90s, for instance. There have been more recently the work by Gallo at IS Global that shows that adaptation already allows to avoid some heat-related deaths during summer. So how could that impact our projections? And when we consider this adaptation, would this change the picture? And there have been some examples of incorporating adaptation in projections, usually focused on some countries. So for instance, there has been this work by Veronica Huber, which implemented shifts in the minimum mortality temperature, and so shifts of the exposure response function by decade to assume some adaptation between heat and cold. And there have been some work also in Munich to model log linear modifications of the relative risk, in particular related to GDP. But this was focusing on extreme. The approach that we use here is rather to devise some adaptation scenarios. So what we did is that we set up some scenarios where the relative risk of heat is attenuated. And I don't know if you see well on this in here, but we have in black our European exposure response function. So this is the average, but our exposure response functions change by city. And so this is what we estimated, and we implement different scenarios, different projection scenarios, where we decrease the curve by a given amount only on the heat part. So the idea with this scenario is that they can represent some adaptation targets, saying, okay, in the future we want to reach some degree of adaptation. And it's also relatively, what I call here driver agnostic, is that here we don't really mind how this is achieved, whether this is by reducing air pollution, increasing greenness, improving the health systems. We don't really mind about that. Here we are mostly concerned about scenarios to provide targets, let's say. And so, actually, this has been shown by Antonio here, but you can. These are the results with the black curve, the black dotted lines that is on top, which are our initial results without considering adaptation. And then when we consider adaptation, there is a decrease of the health impact. And so the one that is very close to the black curve is with just 10% of adaptation, and in this case, it doesn't change the story very much. But we have a change of the story with, let's say, 50% of adaptation, where under SSP1 and SSP2, we see this slight decrease in net temperature-related deaths, but under SSP3, even 50% is not enough to revert this increase in temperature-related deaths by the end of the century. And I would argue that SSP3 is really is a very realistic scenario. So even with important adaptation, we would still see this increase in deaths. And of course, there's a lot of spatial heterogeneity. Typically, in more northern countries, we see across all scenarios a potential decrease in deaths, because in these countries, of course, cold-related deaths really represent a big part of the burden. But you can see that around the Mediterranean, whatever the scenario, we would see increasing related deaths. And so it's focused, for instance, at 1.5 degree warming, it's focused around the Mediterranean area, mostly eastern Spain, Italy, and Greece. But then as we get to more and more warming, this increase in temperature-related deaths spreads more northern to Europe, especially in Central and Eastern Europe. So to conclude on this work, is that we've shown that without any adaptation, temperature-related deaths will almost surely increase in Europe, but that even adaptation, a substantial amount is necessary. So under SSP3, typically even 50%, what we call here 50% reduction of the risk, is not enough. So to put it into context, for instance, 50% is roughly what has been found in some studies across the past decade in Germany and in Spain, and it's much higher than what has been estimated in the UK, Greece, or Czechia, for instance, from the studies that I could find. And so that suggests that, of course, adaptation cannot replace mitigation, so we will need both in the future. And of course, this work is mostly on abstract scenarios, so we don't provide any information on how to achieve this adaptation. But we see this as a first step. So thank you very much, and you can read the paper on the left, and every data, the code, and everything that I've shown here is fully replicable. Everything is available on Zenodo, so just feel free to have a look. And thank you.
So thank you, Per. You finished 2 minutes ahead of time, so that's very good.
That's great.
I don't know, do you want to take questions straight away, or would you prefer to do it in the end? I suggest we take all questions in the end, so we have better control of time, if that's okay. But thank you very much for a very interesting presentation for all of Europe. I think you need this bigger picture to also look at what's possible at very local scales. And I think the result of 50% adaptation not being enough is really, really important. And also the mitigation argument, because I worked in the mitigation field for many years before I moved to adaptation, and it's kind of, you know, you're doing adaptation, then you don't think about mitigation. So I think the message that you need to do both is very, very important. Moving to the second talk, we have a talk now by Frederica Nobile, who's going to talk about a very specific adaptation of urban heat islands. And her topic is urban heat island. I'm not wearing my glasses, so I'm kind of, you know, I haven't brought my glasses either. So urban heat island adaptation science from European cities, I think.
Yes.
Yes. Okay, thank you so much.
So, yes, thank you, and thank you for the introduction. And as said, today I'll show you some results on a study that we have conducted on European cities with a focus on urban heat island adaptation. But it's important to start with the definition of an urban heat island. It is the observed temperature difference where urban areas experience higher temperatures than their rural surroundings, strongest at night. So as We know the surface temperature is move more than the air temperature during day, while they are more similar during night. And we know that we have higher temperatures in the downtown compared to the rural and suburban areas, but this aspect is more evident during night. So if we would focus on a city, we have specific factors that influence an urban Thailand. First of all, the urban geometry, because high building density contributes to the heat accumulation in cities. Also, anthropogenic heat, because the heat generated from vehicles, industries, and human activities increase temperature, but also surface materials and lack of vegetation, because this aspect reduce the cooling effects in cities. So within the Ecatalyze project, that is an European 5-year project led by the ICE Global, we have tried to focus on an indicator to try to understand the element that can contribute to adaptation in cities. The overall aims of the project are to understand how climate change affects environmental risk and their indirect impact on human health, to identify positive health outcomes related to mitigation and adaptation strategies, and also to evaluate how health evidence influence and shape climate-related decision-making. But a specific working package is focused on the building of indicator framework and repository to monitor adaptation, mitigation, and health co-benefits. So within this project, the specific aim of the study that I'm presenting today is to identify areas with a reduction in surface urban Thailand intensity due to changes in green space and or albedo across European cities. So let's start from an overview of the data that I considered. I investigated European cities with a population greater of 100,000 inhabitants. The surface urban Thailand data are based on the learned surface temperature. I used the leaf area index as indicator of the vegetation density and albedo that tell us something about how much sunlight a surface reflects. So for the surface urban island, we have considered the data elaborated by the two authors, and these data are available in Google Earth Engine repositories with a spatial resolution of 1 kilometer, and we consider the mean related to the summer month, particular the night time, for the years from 2014 to 2019. And the definition of the surface urban Thailand is the difference in the land surface temperature between each urban pixel and the average on the LST of the surrounding non-urban pixels within the same urban extent. And we will see an example of this kind of data. Then we have the LAI from the Copernicus land monitoring surface with a spatial resolution of 300 meters, and we collected all the available data of June, July, August for the same years. And the definition and LAI is defined as a total area of green elements of the canopy for the unit horizontal ground area. And we know that dense vegetation and agricultural crops have a higher LAI, while sparse vegetation has a lower LAI. Then we have albedo from Copernicus Climate Data Store with a spatial resolution of 1 kilometer. Also for this indicator, we collected all the available values for the summer month for the same years. And albedo is defined as the fraction of irradiance and reflected by the surface of the Earth, and we know that it depends on the color, texture, and the composition of the surfaces. And surfaces like snow and sand have an higher albedo because they are more reflective, while surfaces like forests and dark urban areas have a lower albedo. So knowing all this data that we have considered, now we can see the procedure that we have considered. And as a first step, we focused on each year and city by pixel level. So we calculated the SUI intensity for the overall period, and then we compared the annual surface urban Thailand and the average period SUI by pixel, and we selected only within a city, only the pixels showing a reduction of the surface urban Thailand with a threshold of 0.5 degree. And in this area that we can call the reduction area, we compared the annual lie and the average period lie, and also within the same thing for the albedo indicator. Then, as a second step, we calculated the mean values of SUI reduction and lie and albedo changes by city for each year. And then, as a final step, we calculated the weighted mean values of SUI reduction and lie and albedo changes over the whole period, so from 2014 to 2019. So now we can see some results. In the all selected cities, so the cities with the population greater than 100,000 inhabitants, we observed a SUI reduction in the 88% of the cities. And specifically, we observed a reduction on average in the 11% of the pixels of the surface urban Thailand, with a mean reduction of 0.7 degree. And this reduction we can see from the plot was greater in the larger cities. And focusing only on these areas with a reduction, we observed an increase in lie, increase that was more variable in the smaller city with a lower reduction in SUI, but is more inconsistent in large cities, while for albedo we observe heterogeneous changes, but more evident decrease in the larger cities, but they are only signals, not a very consistent result for albedo. So to conclude, it's important also to highlight the limitations of this study. The first limitation is the city definition, because we used an European shapefile, so the boundaries not always are comparable across the different city regions in Europe. We use satellite data. This is not actually a limitation, but is something that we should highlight. Then we consider a threshold of 0.5 degree, just a compromise for comparison between across the different cities, and we reduction the analysis to these specific years for the availability of the data when we started this analysis. So to conclude, the variation in climate, urban characteristics and planning interventions could account for the observed changes, but it's very important to highlight that enhancing urban resilience through a combination of green space improvements and albedo reduction strategies can help cool our cities and promote healthier and urban environments. So we can do more for the green space, but as we have seen with our results, we should do more also on the green reduction strategies. So these are the other colleagues that have worked with me on this study, and thank you for the attention.
We take the questions in the end, if that's okay. So please note your questions, and I hope you stay till the end for the discussion. Thank you very much, Frederica. You finished 1 minute before time, so we have a good record here. So we will have more time for discussions, hopefully. But thank you very much for highlighting a very local strategy, but looking at it at a European scale. Green areas are of great interest in Europe right now, so it's very necessary to do these kind of studies. We move on to the next talk. The next talk is about a different kind of intervention. It's related to heat health early warning systems. So it's the first pan-European heat health early warning systems, and it's forecast skill during the deadliest summers of 22 to 24. And it's a talk by Thomas Janos. Welcome. Thank you.
Good morning, everyone. What if I tell you that we can reliably anticipate heat emergencies at least 1 week in advance, and this way we can prevent some heat-related deaths? Sounds promising, right? As already introduced, I'm Tomáš János, and I'm Marie Skłodowska-Curie postdoctoral fellow, and I'm jointly representing Resetox Center of Masaryk University in Czechia and IS Global in Barcelona. And today, within my presentation, we will have a closer look together at what we did within this study and why we concluded as we did. Of course, there were several motivations or several things which motivated us to carry out this study. However, 2 of them probably played a vital role. I believe that this is certainly a well-known fact within this community. European summer 2024 was the warmest on record. But not only summer, year 2024 was the warmest on record both globally and in Europe, and therefore we were curious to know what health impacts could such surge in temperatures had. And for comparison, we also estimated summer heat-related mortality during 2 previous summers, meaning 2022 and 2023 as well. Another motivation is this. This is forecaster.health. I'm not sure if you are familiar with this tool or not, but anyway, this is heat health impact-based early warning system, which doesn't rely on climatic variables such as temperature only, as majority of current early warning systems do, but it takes into account real relationship between temperature and mortality, and therefore it considers real vulnerability of specific populations. So our additional goal was to analyze its forecast skill, especially during such exceptional summers as we experienced during the last years. In relation to methods, I don't want to go into too much details as we used classical state-of-the-art methodology, including distributed log nonlinear models, followed by meta-regression and calculation of attributable number of deaths, or attributable number, yeah. There are just a few things which I want to highlight. For the epidemiological fittings, we used brand new daily regional mortality database of the Early Adapt project, which contains more than 163 million of deaths in 654 regions from 32 European countries. And these are the regions, by the way. And once we fitted the epidemiological models, we combined them with weekly mortality counts for the most recent period from 2022 to 2024, originating from Eurostat. And we quantified heat-related mortality in 2 manners. First, using real observed temperatures, And second, using temperature forecasts 1 to 15 days in advance to see what heat-related mortality burden we are able to anticipate some days in advance. Now results, heat-related mortality rate and numbers. Here you can see heat-related mortality rate expressed in summer deaths per million for each summer. And we can see some differences. For example, in 2022, the highest heat-related mortality rate was observed more in southern western part of Europe, while in 2024 it was more in southeastern part of Europe. And this pattern basically follows distribution of summer temperature anomalies and as well as increased vulnerability to heat in countries around Mediterranean Sea. And these figures have resulted in these numbers, with summer 2022 being the worst and bringing the total burden over the 3 summers to more than 181,000 heat-related deaths. Moreover, in 2024, 15 out of 32 assessed European countries experienced their largest heat-related mortality rates. And these countries are highlighted with small green target here. And regarding the most affected country, it was Italy, with more than 19,000 heat-related deaths during the last summer 2024, and this set primacy was consistent across all years. This plot is already related to early warning systems, and using it, I want to illustrate how we proceeded when evaluating skill of an impact-based early warning system. So this is time series of daily heat-related mortality during summer period from 1st June to the end of September. And this is just an example. I don't remember which year it is, and based on numbers, it seems like aggregation over Europe. However, we did this procedure in each of 654 regions. So we defined emergency days as days with daily heat-related mortality higher than percentile 75. So these are the days on which is the heat-related mortality highest, and therefore an emergency warning should be issued. Should be issued based on real health impact. Then we did the same with heat-related mortality forecasted 7 days in advance and 15 days in advance. And finally, we quantified proportion of days which have been correctly identified as emergency days. For example, here you can see that the system should issue, that on these days the system should issue an early warning. However, it didn't when predicting mortality 7 days in advance. This is called missed warning or false negative, and this is something we want to avoid, of course. Fortunately, there are not a lot of days like this. So we analyzed these time series, and this is basically receiver operating characteristic analysis, usually abbreviated as ROC analysis. And this analysis is commonly used to analyze performance of classification models. You plot true positive rate against false positive rate and get the ROC curve. And in the top left corner, you can see the blue point. This would be the perfect predictive system with true positive rate 1 and false positive rate 0. Of course, closer we are to this point, we have better system, and farther we are, we have a worse system. And here we can already see our real example from Attiki region in Greece during the deadliest summer of 2022. And you can see that 3 days or even 7 days in advance, we are very close to, or the system could very reliably anticipate heat health emergency days. Of course, with longer lead time, the quality gets worse. And these curves are usually summarized as one single value, which is called area under the ROC curve, ranging from 0 to 1. Simply higher means better. So then we can plot all the regions in a map. And these maps are showing results of ROC analysis, summarized as area under the ROC curve values. And here I zoomed in the map legend, so you can clearly see that we are very close to 1. or at least above 0.8 in majority of European regions in each summer. This means that the system could issue very reliable warnings if we do 7 days in advance. And this map, the second set of maps is showing basically the same, but if we do 15 days in advance. And you can see that values are clearly lower, but they are still quite high in some South European regions. And this offers great potential for prevention of heat-related deaths, especially in these highly affected regions, as we quantified that majority, almost or more than 2/3 of overall summer heat-related mortality burden occurred there in these regions. Yeah, and we also tested that, and we proved that in the regions of Southern Europe, the early warning system had significantly better skill at both 7 and 15 days lead times. And we also tested some age and sex-dependent differences, and we found no difference, meaning that the system can issue fair and equal warnings in terms of forecast reliability. And altogether, this have important implications for public health agencies and other potential end users, as adoption of such system would ensure reliable heat health emergency warnings at least 7 days in advance, which is a critical time window for decision makers to take action and avoid preventable heat-related deaths during these heat health emergency days. And yeah, that's all from my side. Thank you for coming and for your attention. And here I'm attaching some links and contact details so you can have a look or reach out later if you want. Thank you.
Thank you, Thomas. Thank you for also finishing 2 minutes early. So thank you for keeping the record. Very interesting talk, and also interesting to see the performance of these early warning systems depending on the time scale. So I think we will have good discussions later on this. I would now like to move to the next speaker, who is Maya Negev. And she's going to be talking about bridging. This is more going from the European level to a national level study, and this is more about bridging gaps in a warming climate, climate change, health inequalities, and everyday adaptation, a national study. So please go ahead, Maya. Thank you very
much. Good morning, and thanks for the invitation. There are places in the front if people from the back want to move forward. There are like 10 chairs.
Yeah, there's one spot free here, so if you want to sit down, please.
Okay. I come from Israel, and I feel I have to say a word about our situation. As you know, we've had the most terrible and bloody war between Israel and Palestine in the past 2 years. And thankfully, as of about 1 week, we hope that the war ended and we can all breathe. So I'd just like to state that I oppose my government's bombardment of Gaza and its civilians and health systems, and obviously condemn the terror attacks of Hamas and hope that peace prevails. But climate change doesn't stop for war, on the contrary, actually. So let's talk about climate change and health. We are focusing on health inequalities, as we saw in the morning in Professor Gasparini's lecture. Everybody's impacted by climate change, but not all are impacted in the same way. Some populations are more vulnerable, and we saw that this is true across all levels: international, national, neighborhood, individual, even within the household. So first of all, at the international level, we published this last week. We show here the polluters on the top. So on the left, by color, the more red, the more emitting CO2 per country in 2019 prior to COVID. And on the right, you can see it in Peter's projection, where the outline, the country's size is not the geographical size by the emissions. And we can see that China becomes very big, US very big, Africa almost diminishes, as well as Latin America. In the bottom row, we see the climate-related mortality. Here we use the heat-related and malaria, which are both climate sensitive, from the Global Burden of Disease inventory. And we see a mirror image. So we see that Africa becomes very big, India and other countries. So basically we have at the global level those who pollute and the others who suffer the consequences. And we see this across levels. Everybody is impacted, but some are impacted more. Going to our national study within Israel, and we are based in the Middle East. It is a climate hotspot. It's getting hotter and drier more than the international average. We are 70% arid and semi-arid. I just learned from the sugar in the morning today. I love this fun fact that Estonia is almost 61% forest, so very different setting. We are much smaller than Estonia, so this is a 45,000 kilometer country. We are 20,000 square kilometer. In Estonia, the population, I believe, is 1.3 million. We have 10 million people, and that's only Israel without Palestine. So you can imagine it's a very, very highly dense region, and that's a part of the reason for the conflict. But even within Israel, we are highly diverse. We have 20% Palestinian residents of Israel, and I will focus on that population later on. Today, I'm presenting a study which we started conducting prior to the war to investigate climate-related health perceptions and needs, risk exposure, everyday adaptation, and healthcare systems' capacity to address these challenges. We started this from the community level. We conducted a quantitative survey of almost 1,500 participants with an oversampling of the Arab population. We did qualitative methods with focus groups and interviews with stakeholders. And right now, we are combining these with our climate data to identify the gaps in the health resilience of the health system and to move on to design policy together with policymakers. I'm showing now a spatial analysis of the survey results. So this is based on what the residents of Israel answered to our questions. The first on the left is vulnerability. So we base here vulnerability on age, gender, ethnicity, non-Jewish, lower education, lower socioeconomic, lower reported health conditions. And as you can see, even though we are a very small country, we have a big center-periphery gap. By the way, our population is more condensed in the north and southern parts, and this is a part of the reason. So we have those who are more vulnerable at the national level. Exposure here is reported. We use several measures, such as working outdoors, and also not owning a private car, because when you own a private car, you have your little air-conditioned box where you can go everywhere, and when you don't, you are much more exposed to the climate, especially in a country where the public transport is not so reliable in the periphery. So you may wait in the sun or a sandstorm for like an hour for the bus to arrive. And finally, the hazard. So this is based on a question where we asked people, have you experienced a extreme climate events? And we can see that it's quite similar. The periphery is higher in all of the IPCC risk in components. From a, hold on, why is it? Okay. From a health system perspective, what is the impact? We've asked people, did you have to cancel a medical treatment or medical appointment due to extreme weather? The results are striking. So within the Bedouin unrecognized villages, these are people in the south basically living in unrecognized towns with no national infrastructure such as roads or houses. We see that 1 in every 3 had to miss a medical appointment. So imagine the impact on their health. In the non-Bedouin Muslims, we see that 1 in 5, and within the Jews, only 6%. So we can see here the intersectionality of different vulnerabilities and how they impact the usage of health services. Next, we try to look at energy poverty, and we ask people, what do you do when it's extremely hot? Extreme heat is our biggest climate hazard. We have others as well. We saw that air conditioning is most frequently used across all ethnicities, but Jews use it more, followed by fan, other home measures such as cold showers. Going out to public spaces was less frequent. Obviously, it's hot outside as well. Visiting family or friends is quite frequent, but some people just bear the heat. Maybe they don't have any means to do anything, and that includes almost 30% of the Bedouins. When we stratify this by age, we can see that we have age differences. So people above 65 in orange tend to use air conditioning less, fan more. And if you see visiting family or friends, so it's 21% in the younger adults and it's less than 10% in the older adults. Often it's harder for them to, be in contact or to move to family or to go visit. Sometimes they are lonely for other reasons, that their social networks deteriorate, and that signals for us that they are vulnerable also in their individual everyday adaptations, means what they can do. I'm going to give a glimpse from the qualitative study just to highlight some of these with the words of our participants. We see the health impacts of vulnerable populations. A lady from a Bedouin unrecognized village said, "We don't have basic infrastructure. I cannot turn the air condition on when it's extremely hot. I don't have a button to press." We see structural barriers. So, for example, a woman who has to go to a medical appointment every 3 months, it was too hot for her. He doesn't have a private car, so she missed the appointment in one of the extreme heat days. We also saw from our focus groups that people report lack of trust in authorities, and that due to that, they rely on their community networks. So my mother's house was flooded. She's elderly. Nobody from the municipality helped. We gathered our neighbors, all of them, during the floods and winds, when men went up and pulled plastic sheets. So people, when they don't have the government or the local government, they help each other. This is a photo from an unrecognized Bedouin village. On the left, it's a health clinic that an entrepreneur from the village initiated. It gets electricity both from solar panels, which are widely used in the unrecognized villages, and from a generator when there is not enough electricity. And if you go inside, it looks like any Western clinic with physician and blood tests and everything. On the right is where the men gather. It's strictly for men, for male, and some female researchers occasionally. This is built, it's based on a tent, traditional desert architecture, I could say, with lots of wind and breeze even when it's hot. And they've added sprinklers from the top of water. So it's really quite nice inside, but it's kind of in-out. But from a gender-based perspective, women are not allowed. So we have these intersectional issues. Just to say that our findings show that climate change does not create new vulnerabilities from scratch, it magnifies existing ones. The most disadvantaged populations are also those with the least capacity to cope. While communities display remarkable resilience, the lack of institutional support and infrastructure leaves them exposed to serious health risks. And from a public health practice and policy, the message is clear. Adaptation must go beyond individual behavior. For example, ensuring mobile clinics operate during extreme weather can prevent treatment delays, addressing energy poverty by subsidizing electricity or investing in communal cooling centers can save lives. At the community level, supporting existing local networks can strengthen everyday resilience. And finally, adaptation policies must be co-created with affected communities to rebuild trust and ensure inclusivity. And that's one of our future challenges. How do we co-create these policies? I would like to thank the project team and the students in my lab. Some of them are here. And invite you to visit our site and contact us for questions. So we are here for the whole conference. Thank you.
Thank you so much, Maya, for a very interesting presentation. Climate change does not stop for wars and doesn't stop either for political viewpoints. So very interesting that you bring that up. I also think the example of Israel is very, very interesting. There are not that many studies that have been done on adaptation in the Israeli context. And I think the vulnerability analysis is very interesting to see the intersectionality in the impacts. So I hope we have good discussions in the end. We move from Israel, which one would expect would be affected by climate change, to the UK, where one expects climate change not to make a big difference. But unfortunately, UK has been plagued with a lot of heat waves in the recent past. And this has made the role of looking at heat waves and adaptation in a UK context very important. So I will now give the floor to Ross. And Ross is going to be talking about looking at, glasses, quite difficult, how to develop national heat warning systems in the UK. I'm not going to bother to read the exact title.
Thank you, thank you. Yeah, so I'm Ross from the Extreme Events and Health Protection team at the UK Health Security Agency, and we sit within the Centre for Climate and Health Security. I think when we submitted our proposal, we were looking at a workshop, so I'm going to try and fit all of that into 12 minutes. So just kind of provide sort of an overview of our Adverse Weather and Health Plan program of work. So as a brief overview of the program of work, which we call the OP, it has 4 pillars to it. So we have the plan itself, which really sets out the adaptation strategy. It provides information around the roles and responsibilities of different organizations, recognizing that it's not all within the gift of health to kind of address these risks. We also provide a range of different guidance materials across a range of different hazards, which include heat, cold, flooding, drought, and we're also emerging hazards like thunderstorm asthma. Everything we do is underpinned by the evidence base. So we have a document which we try to pull all that evidence together into one place, really outlining why we need a plan, who the populations at risk are, and different strategies that we might look at. And then finally, underpinning sort of the response side of all of this is the weather health alerting system. So in terms of the plan itself, it was a deliverable under the National Adaptation Program in the UK. And really, we brought together the old heatwave plan for England and the cold weather plan for England, recognizing that the frameworks for responding to these events were, they're shared sort of things to be looking at. And also, that was the way that our stakeholders were going at the local level. And within the plan, we now have specific goals which we're trying to achieve. And sort of the role of monitoring and evaluation is really key to this. So the way the plan is sort of laid out is across these 9 action areas. And everything that we do as a team really falls within these 9 areas. And I think for the first time, we've really tried to focus on sort of the quality of what we're doing to give our stakeholders assurances that we are doing things to the highest of quality, but also ensuring that we are providing data analysis to demonstrate the impact that we're actually having. In terms of the guidance, I won't dwell on the guidance for too long, but we have a range of different products across the different hazards, which are publicly available, and they range from guidance for professionals right through to public-facing advice and sort of leaflets and infographics and things like that. As an example, this is for heat. So we have 18 different products, and they span guidance documents, which kind of describe best practice for things that professionals can do, from commissioners to providers of health and social care, voluntary community sector, and sort of national organizations. We have action cards, which outline suggested actions during different alert types, and summary action cards, which are sort of a one-pager kind of reminder during an event, as well as public advice, like the Beat the Heat poster that we have. And I think one of the great things that we've been able to do is actually translate those into the 11 most spoken languages in the UK to really make sure that it's equitable, and that the message we're putting out there are available to everybody. In terms of the supporting evidence document, so this is published alongside the plan itself, and as I mentioned, it kind of tries to pull that evidence base together into one place. And everything that we do, we want to be able to draw a direct line back to the evidence base. So the first iteration of that was really just combining the making the case documents from the cold weather plan and the heat wave plan. And subsequently, we've started elaborating on some of those sort of chapters and adding extra hazards in there as they kind of are ramping up the agenda, like thunderstorm asthma. So I won't dwell on that for too long. And then underpinning the response side is the weather health alerting system. So we have now moved to an impact-based alerting approach, and that essentially means we are providing information on the impacts we think will happen as a result of the forecast weather. So going beyond just the fact that there's hazardous weather on the way. And this is a joint sort of responsibility of ourselves and the Met Office. And I think one of the things within this whole program of work that is really key is that sort of collaboration and partnerships across different organizations who have expertise that can kind of work with our expertise, as it were. So with that in mind, in terms of the decision-making process that we go through, so we have alerting decision-making aids, thresholds, which are essentially based on the underlying epidemiology, so the temperature-mortality relationships. But what we've found is the most useful element of this is actually taking that into consideration as well as everything else that's going on across the system. So we know that it's not just temperature that's driving the impacts that we see year on year. So within this framework of our decision-making, we consider the forecast, we consider the temperatures, but we also consider what time of year is it? Is it early in the season? How many heat events have we had? What other concurrent hazards are happening that might amplify what we're seeing? And that's a joint discussion between ourselves and the Met Office. And through that discussion, we'll come to a joint decision about the impacts we think we will see and the likelihood of seeing those impacts. And if we think for heat specifically, it's going to impact the health sector only, we will go ahead and issue a heat health alert. But where we think other sectors might be impacted, that triggers an escalation to a cross-government discussion. So it's no longer just meteorological services and health, the civil contingencies sort of coordinators, so the Cabinet Office in the UK, but other departments, so Department of Transport and so on, all come together and discuss kind of what we think this event is going to kind of bring. So in terms of the alerts themselves, they are emailed out. People have to register to receive them. And I think by now we've been issuing heat health alerts and cold health alerts for over 20 years. And this is now really well embedded across the emergency planning sort of structures. And the idea is that we will issue the alerts via email to those who are registered, and then local organizations will have internal cascading mechanisms to make sure that the alerts get to where they need to on the front line. But we also know that this is public information, so we need to make it freely available. So we also now have the alert information on the UK HSA data dashboard, which is our, I guess, focal point for public health data in England. And that is publicly available, and we know that people are going to this when we issue alerts. So just this summer, I think every time we issued an alert, the dashboard traffic went up 98%, which is pretty big. So we think people are looking at this and paying attention to this. It's headline news as well every time we issue an alert, whether it's a yellow or amber. And I think I've got one more, or maybe two more slides, but just to demonstrate the role of coordinated response. So I'm actually speaking tomorrow about the mortality work that we do. And this is just one little glimpse of that. But in 2022, we had the hottest event in England where we breached 40 degrees for the first time. And within our mortality reports, we are now comparing the excess that we calculate versus what we would expect based on the previous 5 years relationship of temperature and mortality. And during that record-breaking period, we actually saw, I think it was about a 25% lower mortality than the models would have expected. Now, we can't draw a direct line from that apparent reduction to our actions, but triangulating that with other evidence base, so qualitative evidence from the Met Office, for example, that suggested during this event 98% of the public actually took some form of action. And we combine that with subsequent years, and we're starting to build some evidence around, we think that people are taking action during amber alerts, so those more kind of serious and impactful events. But we have some work to do in terms of the yellow. So 2023, 2024 insights from our mortality reports are suggesting that we might be seeing more than we would have expected. And so I think there's a behavioral aspect to this in making sure that the messages we're putting out are actually leading to the actions we want. So I think at an extreme level, we're seeing success. More moderate, probably not. And so there's real work for us to do there. So yeah, I will stop there. I think the key point from me around the whole adverse weather and health plan is that cooperation and collaboration with other non-health experts and really building on each other's expertise to kind of address the whole, as much of the issue as we can. So yeah, thank you.
Thank you so much, Ross. I'm always impressed. I've heard Ross's talks before, but I'm always impressed by the level of science and community and all the collaboration that goes into building the health services in Britain. And I think you will be a blueprint for many countries which are looking to build these kind of services. So thank you very much for an excellent talk. We move to the next speaker. Is it Lei Yuan? Yeah. And you're going to be talking about climate change and human adaptability, an integrated framework for historical insights and future capacity. So the floor is yours.
Okay, thank you everyone, good morning. The title of my speech today is Climate Change and Human Adaptability, an integrated framework for historical insights and future capacity. I'm Lei Yuan, I'm from the Department of Global Health Policy at the University of Tokyo. So this is the outline of my presentation today. First, I would like to give some background information about the temporal changes in the susceptibility to temperature, and then jump to the key point of today's speech, that how to assess the human adaptation capacity. I would like to introduce our proposed adaptation modeling framework using the threshold temperature, and then I'm going to show you the application of this framework using the real data in Japan over 5 decades. And then in the last, I will summarize the key findings and also give some implications from our study. So I think this slide is you must be very familiar with this slide. Professor Gasparini, in his paper, showing that the nonlinear association between the non-optimal temperature and mortality across many global countries. So both heat and cold are associated with increased risks of mortality, and the threshold temperatures at which the mortality risk are at its lowest is called the optimal temperature, or the minimum mortality temperature, also called MMT. So But despite the adverse health impacts of the climate change, people can somehow acclimatize or adapt to the local climate and also the rising temperatures over time. So there are two types of the acclimatization or the adaptation. One is short-term adaptation, which can occur in days or 2 weeks, and from days to weeks, not 2 weeks. So the previous epidemiological studies from the MCC design also show that the heat-related mortality can reduce from the early summer to the late summer, so showing some evidence of the within-season adaptation. And also there are long-term adaptation. This can due to the physiological acclimatization, for example, the more efficient sweat glands and the lower basal metabolic rates can help people better tolerate with the heat. And also there are some behavioral reasons that people change the lifestyle, for example, dressing properly during the heat or the cold season, and then the usage of the AC, air conditioning, and the heating. So as a result of this long-term adaptation, geographically speaking, the MCC study showed that warmer areas have higher MMTs. And also, temporally speaking, the MMT can also increase over time, as shown in the bottom figures. So, the previous studies on the historical trends of the temperature mortality associations have provided valuable insights into population adaptation in terms of the susceptibility change over time. They mainly focus on the temporal variations of the changes in the slope of the heat-related risks or cold-related risks, as well as the threshold temperature changes. So, for example, here these exposure response curves in Japan for over 5 decades, from 1970s to 2010s, are shown in the exposure response curves by different cause of deaths. So while a constant attenuation was observed for the heat-related risks, however, like many other countries and places, changes in the cold-related risks often exhibit more irregular patterns with inconsistent directions, making it very difficult or challenging to draw the conclusions of the shifts in susceptibility across the entire temperature spectrum. So in this context, using the threshold temperature as an indicator offers a more comprehensive approach to assessing the susceptibility change across the full temperature range, thereby simplifying the interpretation of the adaptation dynamics. So under global warming, an increase in the absolute threshold temperature, MMT, is expected even in the absence of adaptation. However, the relative threshold, MMTP, provides a more informative measure of adaptation as it accounts for the changes in the temperature distribution. Theoretically, a constant MMTP indicates the full adaptation over time, while an increasing MMTP indicates the evolvement of non-adaptive mechanisms that could attenuate the adverse health impacts of the rising temperatures. But the changes in MMTP alone do not fully capture the magnitude and direction of the adaptation. So how to assess adaptation capacity is crucial for quantifying the current and future health impacts of climate change, because most existing projection studies assume a constant pace of adaptation and assume there is no limit of adaptation. So here, to directly evaluate the temporal trends in the pace of adaptation on a nationwide scale in a more straightforward way, here we propose a comprehensive spatial temporal adaptation framework to assess the adaptation changes over time. So this framework includes two analytical components. The first one is we need to assess the changes in the threshold temperatures, both in the absolute term and the relative terms, across the defined subperiods. And then we will obtain the temporal changes in the relationship between the ambient mean temperature and these threshold temperatures. So under the assumption that no other factors would influence the susceptibility to the temperature, an increase in the MMT that parallels a rise in the ambient mean temperature indicates a full adaptation to the local climate. So in such a scenario, a 1 degree Celsius increase in the MMT corresponds to 1 degree Celsius increase in the ambient temperature. and MMTP remains constant, this would yield a slope coefficient of 1 for MMT and 0 for the MMTP within each subperiod. So for MMT, a beta between 0 and 1 suggests that the MMT increases at a slower pace than ambient temperature, and a beta of 0 indicates a constant MMT with no adaptation, while a negative beta implies a shift in the opposite direction of ambient temperature change, indicating the maladaptation. So for MMTP, a negative beta indicates a diminution or absent adaptive response as a relative threshold declines despite the rising temperatures. It is also important to clarify the distinction between the susceptibility change over time and adaptation. So as an increase in MMT or MMTP may result from the real adaptation, but it can also be led by the non-adaptive factors that concurrent happened that could lead to the increase in the thresholds. Such non-adaptive mechanisms can contribute to the alongside the adaptation and can result in the slope coefficient exceeding 1 for MMT and also exceeding 0 for MMTP. So our primary focus is on the temporal variations in the slope coefficients of the associations between the ambient mean temperature and the thresholds across subperiods, which we interpret as reflecting the changes in adaptation over time. So here I show the real application using a case study in Japan. So data is the daily time series data on mean temperature and mortality from 1972 to 2019. And then we use subperiod analysis each by 1 decade from 1970s to 2010s. The first step is to obtain the first component, as I mentioned before, to assess the time to assess the subperiod specific and the location specific threshold temperatures using the time series regression model and their standard errors. And the second step is to obtain the second component, the time varying associations between the ambient temperature and these threshold temperatures, accounting for the standard errors using a mixed effects meta-regression model. And also this regression model further includes some additional individual or simultaneous adjustment for the various location-specific climatic, demographic, socioeconomic, medical resources variables, as well as air conditioning. So we also perform the subgroup analysis for the above analysis by region, for example, the north and the south part in the age group, as well as the sex. So this is the results for the first component, the temporal changes in threshold temperatures in Japan. So our findings indicates that an increased over time MMT and also MMTP align with previous local evidence, with similar patterns observed also for the cause-specific mortality, although didn't show here. But we also found consistent results with local and global studies examining the susceptibility change across population characteristics, which indicate a greater decline in susceptibility among the elder population and also among the females compared to males. So subsequently, for each subperiod, we ran separate meta-regression analysis to examine the time variant association between the location-specific MMT or MMTP and the annual mean temperature. The relationship between the threshold temperature and the mean temperature suggests a slight overall increase in the to the rising ambient temperatures. However, the direction and the magnitude of this adaptation fluctuated across the subperiods. For example, from the 1970s to 2010s, historical adaptation initially accelerated during the earlier decades. For example, from 1970 to 1980s for all-cause mortality in the general population, but gradually slowed down with a declining magnitude in subsequent decades. Similarly, the coefficient for the MMTP showed a rise initially, then remains relatively stable or slightly declined in the later decades. And further subgroup analysis reviewed the variations of historical adaptation across the populations, despite a constant overall increase in the increasing trend for the both MMT and MMTP. So to summarize the findings of this study, we found the unparalleled pace between the rising temperatures and the threshold temperatures in recent times. And also the adaptation pace showed an upward trend in the earlier decades, but declined in magnitude in more recent years in Japan, indicating the room for further adaptive capacity. And then the implications I want to emphasize is that our results indicate a change in rather than the constant pace of adaptation to climate change. This is contrast with most existing projection studies that assume a constant pace of adaptation when estimating the future threshold temperatures. And also, but more empirical evidence of this pace of adaptation is needed because this is the first framework, and then we proved using our case in Japan. So we would want more improvements in the projection studies incorporating your local evidence of this adaptation pace to better account for the observed changes in adaptation dynamics. And also big thanks to the co-authors, Aurelio and Chris and Professor Hashitsme. If you want more information about the cause-specific mortality, and also we try to differentiate from the real adaptation between the non-climatic adaptation factors, you can search the title, and this paper will soon be published by the Environmental International. Thank you for your sharp attention.
Thank you very much for an excellent presentation, kind of drawing all the presentations together from the European to the national scales and highlighting the problems that still exist in these kind of modeling studies at local scales. So thank you for that. We now move into the discussion section. We only have 2 mics. So what I suggest is if it's possible for all the speakers to come up here, so we don't have to run to the speakers, if that's okay for you. We have more mics? Okay.
But not maybe 7.
Not 7, yeah, we counted and we weren't sure. I was thinking of making you sit down. Would you prefer to sit down? That's also possible. Since there's 7 of you, we can pull up some chairs, or should we just allow them to stand?
It takes time.
Okay.
Yeah,
Okay. Hans has the final word since he's organizing here. So we move into the discussion. I hope you've noted down your questions. Now or in the end, or all of them?
Yeah, maybe on the stage.
Yeah, come on to the stage. They want to take a picture of you. So, yeah, for life. Oh, sorry. Yeah. Yes, please go ahead with your questions. If you know who you're directing them to, then please name the person for whom the question is directed. Yes, yes. Go ahead, whoever puts their hand up first. Yeah, he has his hand up first.
Hi, Tom Addison from the Physiological Society. Ross, I wanted to ask you, you mentioned the cross-departmental work that you do through the Cabinet Office. I wondered if you could just say a little bit more about whether that sort of need or demand for information is kind of two-way. So, you know, are those departments you mentioned, like transport, are they coming to you to say, we're noticing a problem at certain times, but we don't know why we're getting it at certain times. So, you know, can the UKHSA shed some light on it? Maybe not transport, maybe another department, but yeah.
Yeah, sure. So I think 2022 was quite enlightening for a number of different reasons, even across health. So public health, you know, we don't necessarily have levers for action within, say, care homes, for example. We don't have levers within the justice system for prisoners. Yet we've been trying to get inroads because we know that's a vulnerable population. During the 2022 heat event, we had those departments coming to us saying, oh, we haven't prepared for this, so can you check our guidance? Does this make sense? And since then, I think that level of engagement has remained high. I think the 2022 event really made people aware this isn't something that's in the 2030s, which isn't that far away now, or the 2040s. Like, this is happening now. So yeah, I think it is two-way now. It may be previous to 2022, it was a bit of a knocking on doors and getting no response, but I think that is changing.
Hi, I'm Kristoffer Mattisson from Lund University. I have a question to the second speaker, Fredrika. I was wondering, you presented that there had been an increase in leaf area index for a certain percentage of the pixels that you studied. I would like to ask, what about the other pixels? For how large percentage do you see a decrease? And also, do you know, for these pixels where you see an increase, have you studied if it's due to that there is an increase of the extent of the urban greenness, or if it's due to increase in biomass production?
Okay, yes. The results that I presented are kind of preliminary results because we are exploring this topic. And then so we started focusing only on the pixel with a decrease in SUI because of adaptation. So we would like to see what has happened where we have seen a decrease. And so the main result is that linked to this decrease, we have an increase in lie, so in the value of the lie. So this is related to, yeah, we know that the lie is not, it's a proxy of a vegetation density, not we don't know the type of the green space. So an idea that we would like maybe to explore more is trying to split all the pixels related to the type of change in SUI and see the changes of the other two indicators in the specific group. So maybe looking at this, we can kind of increase our understanding of the complete picture. But yeah, I don't know if I have answered to your question.
I think so, yeah.
Okay,
Thank
perfect.
you.
Hi, everybody. Excellent set of presentations. I have a question for Thomas. Incredible work. I was quite interested in seeing the difference in performance across Europe, basically, with a lower performance in Northern Europe. First of all, a question that you can answer later if you plan to do some work on that in terms of looking about the specific reasons. And then a comment. This can be due probably either to the forecasts, basically, how good are the forecasts in the future, for example, in the 10 days or something, but also probably the weaker signal that you have for the exposure responses in those places. And maybe a way to address it, it will be to rerun the health forecast impact with the observed temperature data. So if you compare the two, I mean, the forecast with the forecasted temperature and the forecast with the observed, you have an idea about how much important is the climate component in that. And I wonder if you plan any further analysis on that.
Yeah, thank you very much for your question. Yes, we do plan to analyze these spatial differences in forecast scale. And yeah, basically there might be difference in forecast of temperature, like a scale of temperature forecasts, but we think it could be somehow related to the shape of the curve, because in southern European regions we might see very steep increase in heat-related relative risk. So yes, this is something what we are going to study. What are the basically what is behind this pattern which we have observed. I'm not sure if this might be caused by signal you have mentioned, like number of heat-related, lower number of heat-related deaths in northern part of Europe, because as I said at the end of the presentation, we compared also, or we studied differences based on age. And for example, for the elderly, or 80% of heat-related deaths occurred among the elderly, and we saw that the scale was equal or was similar to the scale among the younger population. So I'm not sure if the real number of heat-related deaths might explain that, because if so, then we would see worse scale among younger and men, for example. But yes, we need to go in more deeper into this topic, and we want to study.
Yeah, basically, my point is, if you should focus on improving the weather forecast, or we should probably, which I think, improve the estimation of the exposure responses for that specific population, in terms of forecasts.
Yeah, I think we can improve both, like forecasts and precision of exposure response function to improve the scale of the early warning system. Yeah. Thank you.
Hello, my name is Neil. I'm from Barcelona. Also, but studying in Uppsala University, master in law. My question is more related into this field. How's your relation for the second and third speaker with public institutions? mean implementing measures about your data. You work in different fields now. For example, she's working with Copernicus, I think. And once a measure is implemented, there's any kind of monitoring, constant constant communication with the public institutions? How is it? Thank you.
Yes, if I can, or do you want to start? Yeah, if I can start. We are in close contact with the Public Health Agency of Catalonia, Catalan Public Health Agency, and we are currently developing for them like more specific with better, higher resolution early warning system. We also need to hear their needs. So yeah, right now, because this was European-wide, the regions are still quite large. We need to go like to lower spatial level, and this is something what we are currently trying to develop for Catalonia in cooperation with Public Health Agency of this larger region.
Yes, so not my main field, but this presentation is related more to the exposures, so to something that comes before the health outcomes. And at my lab, because I work in Rome in a department of epidemiology that is very linked to the region, so we have kind of a constant dialogue with the region in terms of improving also some aspects and related to the urbanistic of the city. So it's a difficult dialogue because not always we have a quick response related to our results, but at least we have this dialogue, and I think it is important. So we don't see indirect results of the discussion, but is a field and a communication that is going on. So we hope that we can do something in this way. Yeah.
Thank you.
Yeah, thank you. I would like to raise a question to Monsieur Maslow. I think that I agree with you that the role of local regional authorities is crucial to respond to the challenges in the field of health and climate. And did you analyze the experience of the European cities, municipalities that have a particular experience in overcoming health and climate challenges? And I know that, for example, Council of Europe and its Congress of Local and Regional Authorities created a network of European cities, municipalities suffered from natural and technical disasters. Did you analyze in your work the experience of these municipalities? I mean, Toulouse, Yerevan, Slavutich in Ukraine, Chernobyl disaster. Did you collect this experience of these municipalities? Thank you.
By experience, you mean what has been done at the local level? You mean what kind of actions has been performed? Because in this work, we didn't go into that level of detail. What was included in the modeling were some, let's say, local characteristics. So for each cities, we had, for instance, the amount of greenness, the pollution, these kind of things that inform our modeling. But in terms of more specific action, and if this is what you mean by experience, this isn't something that has been incorporated in the modeling. What I can say about that is that this work starts being used also, discussed at least in some cities. I've been contacted by some people at the municipality of Paris, for instance, by the C40 network, these kind of things. So this is used. Yeah, I hope I got the gist of what you were asking.
Thank you very much. I would like to go to the two speakers who haven't had a chance as yet to respond to questions. Maybe first to Maya I'm taking the privilege of being the chair in the last 1 minute to ask my questions. I had a lot, but you guys took over the floor. So my question is, in your presentation, in the last slides, you highlighted how individual and entrepreneurial efforts are somehow dominating the scene in the Israeli context compared to governmental interventions. And people tend, coming from a hot country, originally myself, people tend to think of heat as a given and something that you just have to live with. If it gets hotter, that's not really the government's problem, it's your own problem. So is that the right interpretation of your slides?
Thank you. It's a great question. Heat is taken as a given because even a decade or two ago, we did have in the summer 40 degrees occasionally. Many people are aware that it's getting hotter and that we have longer and more extreme heat waves. And they are doing their part. I think that until recently, it was not on the government agenda, but in the past few years, and with a lot of inspiration from what's going on in Europe, specifically in the UK, the Ministry of Health is now, about a few months ago, they launched their first adaptation plan. And across the different departments, they are starting to talk about it and to understand that they have a role and that it is a multi-sectoral role. So I think we will see some progress and that we really need the top down, because the bottom up is an emergency, first response, but it's not enough.
Yeah. Thank you very much. And then to the last speaker, Leo, you had an interesting case study where you looked at the attenuation and looked at how variation can then, it implied in your presentation that there was a kind of slowdown of adaptation in a historical context in Japan. Can you give us some more details? Why did adaptation take off and then slow down? Because I think it's very important also for Per's slide in the beginning, which talks about extensive adaptation in the future.
Yeah, thank you for your question. Actually, that's also a key highlight of our paper that I didn't have time to address. So actually, when we, because we collected many location-specific indicators of the demographic and the socioeconomic, and also the air conditioning, we show the time series plots of their trend, and we found that the economic, it rapidly increase in terms of the income levels, household income levels, it increasing dramatically from the 1970s to 1980s and also 1990s, but later because of the bankrupt of the economy. So it's just keep stable or slightly decrease and then rebound to the level and then remain constant. So, and we think that might be the possible explanations. Yeah, thank you.
Thank you very much for excellent talks and excellent replies. We are at the end of our session, and thank you to the audience for very good participation. I hope you enjoyed the session, and we now have our coffee break. Thank you.
Lunch break.
Hey, Anna. I'm Mari, yes. I just Anna Cronin de Chavez? Is that right? Anna Chavez. Okay. Sure. So, good afternoon, everyone, and welcome to our session of Community-Led Solutions in Citizen Science. My name is Marela Sundström, and I'm a senior scientist and associate professor at the Institute of Environmental Medicine, Karolinska Institutet in Sweden. It's a real pleasure to have you here in this NBEL session, a part of the conference that brings together people who care deeply about how climate change affects health and how communities can be part of the solution. This session focuses on something both simple and profound, the idea that climate adaptation and resilience begin where people live. We will listen to 5 talks, each presenting work that highlights different ways communities engage with and respond to climate risks. Each presentation will be a maximum of 10 minutes, and I will try to sign when there is 1 minute remaining. And I hope that after each talk, we'll have a couple of minutes for questions from the audience. So let's begin. Our first speaker is Devin O'Donnell, who is a doctoral researcher at the University of Sussex. Devin's work examines how to advance the implementation of climate and health solutions through policy and governance, knowledge mobilization and communication. And looking at cities as an example, her research helps us to understand how local governments can better integrate health policies into climate policy. So please welcome Devin O'Donnell.
Great. We have a tech team in this room. Hi, everybody. So for those of you who saw me speak earlier, this is a shift in topics here. We're talking about city policy. How many of you live in a city? Almost everybody. And then raise your hand again if you have any idea what your city is doing specifically on health adaptation. Okay, we got a couple that maybe some questions. So this is what we were trying to figure out is how are cities integrating health and equity into their climate adaptation plans. And we looked at 55 municipal climate action plans. These were cities that are in the C40 climate leadership group and plans that have been published since 2016. And we classified each of these documents with what we call the health prioritization level. So we found that 20% of plans didn't include health at all. So maybe the word health is in there, but it's nothing more than climate change impacts health. 29% acknowledged the health impacts of climate change. So this means that there probably was a background section that integrated kind of the different ways in which health and climate intersect for this particular city. However, they didn't integrate health into their adaptation strategies. 40% considered the health impacts of climate change. So this means that they had at least one of the health adaptation strategies that we were looking for. However, this often would be a health adjacent type of strategy. So maybe it was an early warning system or like hazard and vulnerability mapping, for example. Only 11% of cities we found were committed. So this means that they would have had really health primary strategies, something like health system strengthening or disease surveillance. And none of the cities met our definition of prioritized. So to be prioritized, they would have needed to have comprehensive adaptation strategies that spanned different areas of health. And I list all the cities here so that you can see kind of visually where we sit. And you can see that kind of the vast majority of cities are in these middle 2 categories. So, you know, there is some work being done here, but there's a long way to go. So geographically, these are the 55 cities that we looked at. Then purple here are the committed cities, and we did find that there was a trend for cities that were in low and middle income countries tended to have a higher health prioritization level. But we also categorized each document, we coded them across 13 different themes around health, around justice, and around implementation readiness. And I'm only going to touch on the health themes here, but there are other areas that I won't mention. So the first column is showing the different categories of health themes that we coded for. The middle column is showing different examples of what that might look like as an adaptation strategy. And the last column is showing the % of documents that had each of these different areas. So climate hazard and vulnerability mapping is pretty much what it sounds like. It's some sort of risk assessment. About half of the plans had this. Early warning systems mostly looked at specifically at hazards, mostly floods, occasionally drought. 10 of the plans had heat and 2 had disease-specific early warning systems. Heat action was also quite common. This most commonly was things like occupational work standards, so maybe adjusting work hours. It could also be establishing cool shelters or adjusting green and blue infrastructure, or lastly, things like public awareness campaigns. Disease surveillance was found in about 25 plans, so this mostly would have been just basic surveillance measures. Occasionally, it also included things like vector control. Health systems were sometimes included in plans and would often, if it was included, it would have been something like training healthcare, health staff. It could have been adjusting systems capacity for surge capacity, for example, or things like investing in climate and health research. Mental health was only found in 3 plans, so that's 5% here, and that most commonly looked at something like integrating psychological first aid training into first responder training, or adjusting communication so that it's potentially not triggering the public in different ways. And lastly, we looked at social health, and this would have been things like establishing resilience hubs or having elderly social support networks. And I just want to point out briefly, similar to what I had previously mentioned, is that here, looking at the percentages, you really see that where there is a majority of these adaptation strategies are in what I would kind of call health-adjacent topics. So you could have an early warning system for floods that does not mention health at all. So there is still a health benefit to that system, but for these really health primary areas, like health systems, like disease surveillance, like mental health, we're really kind of still falling behind in terms of how these are integrated into city planning. There was a huge amount of variation in terms of the type of and detail in these strategies. So this is an example of one of the mental health strategies. There's a decent amount of detail here. This is talking about training psychological first aid, or giving psychological first aid training for first responders. But they're still missing some information that would be quite helpful. We don't know how many trainings they're planning on doing, how many people are they planning on training, by when. You know, we're still missing metrics here. But it could have also looked like this. So there was a huge problem of vagueness, of lack of specificity across all of these areas. So this really does not give me any sort of idea of what the city is planning on doing in terms of mental health. And I also think that the city probably also doesn't know what they're planning on doing. So I want to touch briefly on kind of why this matters. Why should we care about city policy? And this is showing kind of a simplification of what the international climate and health policy landscape looks like. So you have the international level, you have these big agreements coming out of things like COP. WHO is quite active in this area of helping to establish these declarations. You have the national level, you have these areas being translated into nationally determined contributions, or potentially countries that are developing HNAPs, Health National Adaptation Plans themselves. However, the biggest issue is that these are not being implemented. So the latest report from WHO found that only about half of HNAPs have even begun to be implemented. And that number is a bit out of date now. I think they should be having a new report come out on that soon. So you really need to start looking at these more local levels to not only figure out what's being done there, are they having strategies on these local levels, are they implementing them, but also those local levels is where the implementation happens. So even if you have a national plan, it's being implemented more locally. And I just want to point out that this is listed in a decreasing geographic scale. It's not listed in influence. So just to point that like a city, for example, is not necessarily only implementing what is in these national and international agreements. There's also space for local levels to be innovators and to kind of set the standard of what health adaptation could look like. But even more so, I want to connect this to impacts and think about, when we think about health adaptation and planning, what does this actually mean on the ground? And this is a picture from 2 years ago from the 2023 floods in Libya. It was a really disastrous flooding event. 2 dams broke outside the city of Derna, and almost 5,000 people died, lost their lives. And I point this out because when we think about the adaptation strategies that I mentioned here in terms of what counts as health adaptation, would any of those strategies actually have changed the outcome here? Potentially, there could have been some change, right? If we had a stronger health system, maybe there would have been something different. Maybe we had better disaster response. However, there's fundamental challenges here that are leading to those types of mortality counts. Another example is this is the flood from Texas from a couple of months ago. This was a flash flood, so an early warning system wouldn't have been very helpful here. You're still having people that are building in flood zones. You have a government potentially that's withholding aid. So you have all these other things that are contributing to negative health outcomes in these situations. Last example is how social isolation, for example, is tied to heat mortality, particularly in elderly people. So for example, if we invest in stronger health systems, that might help reduce that mortality by a little bit, but at the same time, how can we also invest in social systems and social strengthening and social resilience as a way to also reduce the mortality count? So I think there's an opportunity here to potentially expand the way that we think about health adaptation. If you're curious what that might look like, check out my poster downstairs. But just to summarize very briefly, kind of the main, and there's much more in this paper, hopefully it will be published quite soon, that you can read more about what we talked about in terms of justice and equity and also implementation readiness, which I don't touch on at all today. But this cartoon is really kind of summarizing the main theme that we found, which is the awareness is there. We know what's happening. We know kind of what's coming at a city level on climate and health. We're not doing enough. So how can we start to do better and have more implementation, not even just design, right? We're looking at design here, not even implementation. And I also want to thank my co-author, Benjamin Sophocles, for his work on this paper as well. And if you're interested in this work or other work of the Bennett Institute or the C40 Center, you can check them out there. Thank you so much.
9 minutes, 11 seconds. Are there any questions?
Thank you, that was really interesting. Can you say something about how you chose which plan to evaluate? Because I know that some cities, like New York, has many, many adaptation plans that have been developed over the years.
Yeah, so we use the CDP database. So CDP has a city-specific database for adaptation strategies, and we use that as our basis. So whatever the city is determining is their most adaptation-relevant plan, because it's all self-reported, is going into that database. And so that's what we started with and used it, and then we narrowed it down from that database to C40 cities and plans published since 2016.
Any more questions?
I'm kind of curious if you think there might be some plans that governments are doing that are not explicitly put as climate change plans, maybe like now because of the political climate itself, but also just, you know, if it's about human health and safety, maybe there's things they want to like fix without really making it clear what the risks might be beforehand.
Yeah, I mean, I think that one of the biggest challenges to this is what you allude to as well, is that there's a lot of different plans that are probably relevant to both health and to both climate, right? So how do you identify what is the most useful? We did use something that was self-reported, so here we're assuming that the cities are giving us the plan that they think is most relevant, but you're right, there could be, maybe there's an occupational plan that's super relevant, that's going into all of their different health workers standards. So there is a lot that's actually probably missing here, and that's a limitation. How do you say, where do you stop, right? Like there has to be a place that you stop, but that could definitely be a different study, is looking within one city specifically. New York is a great example of this. They have a lot of different plans, and looking across their different plans and actually maybe finding which one is actually the most relevant for resilience, right? Because there's a lot of different ways to look at it. Yeah, thanks.
Thank you so much, Steven. Excellent talk. We will now move from city-level planning to public health implementation in practice. Our next presentation is by Dr. Martina Ragetli from the Swiss Tropical and Public Health Institute. Martina leads research on health effects of environmental changes and the effectiveness of adaptation measures. And today she will share insights from her study on the implementation of heat health actions plans across Switzerland. So welcome, Dr. Ragetli.
Yeah, thank you for the introduction. Yeah, I will talk about heat and health in Switzerland. The federal government just in June this year acknowledged extreme heat as Switzerland's top climate change risk, and also puts strengths that we have to act. And actually, since 2003, authorities have implemented various policies in Switzerland to mitigate the heat health risk. These are, for example, information campaigns, how to behave during heat waves. Then, of course, we have also a heat warning system, and there are various strategies to also make the cities greener. But the special case in Switzerland is that we are a small country, and we have 26 cantons. And each canton has its own health department, and they are actually in charge to implement policies. Now, after 2003, the cantons in the Italian-speaking region and in the French-speaking area, they actually implemented heat health action plans. And in the rest of Switzerland, they also implemented some single measures. Now, in Switzerland, we have at the moment 2 monitoring systems to assess the effect of heat on health and also the effect of such policies and also the effect of implementation. So we have the monitoring of heat-related deaths. I will not talk about that. And now I will talk about the project or the program of the Federal Office of Public Health, where they assess each year since 2003 a different stakeholder group that responds to such policies. So 2003 it was the population older than 50 years. So we asked them, what do you know about heat and what do you do when it's hot? Then, and this is actually the focus of this presentation, the cantonal health authorities, we did an online survey among all the 26 cantons and asking them what measures are in place. Do they have a heat health action plan? What are the barriers and the success factors? And also, what is their opinion towards a more coordinated action among all the cantons? And then ongoing is now a survey among health professionals. But I will focus now on the survey we did among cantonal health authorities. And here are some results. So it shows the map of Switzerland. In blue, you see the cantons that have heat health action plans. Still in 24, the cantons in Italian and in the French-speaking cantons, but also in German-speaking area. Slowly, they start to develop such plans, shown with the dotted cantons. And there are still 8 cantons that don't have any engagement on the level of the public health department, and these are mainly alpine regions. But in general, we see a growing engagement also in the German-speaking cantons. Then, most of you are familiar, I guess, with the WHO guidelines on heat health action plans. So there are 8 core elements, which you see here. And on the top row are the 26 cantons. And based on what we got, the information from the cantons, we evaluated which of those core elements are actually implemented. And this black frames the cantons that have heat health action plans. So at least 5 of the core elements are implemented. So all of these cantons, they have a lead body, so that it's usually the department, the health department. They use a heat health warning system. They have a communication plan. They have information how to reduce indoor exposure. Also, they focus on vulnerable groups, so they have various measures to protect the most vulnerable populations. But what is actually missing, so only very few cantons engage in the preparedness of the health and social system. So for example, helping hospitals or elderly homes in preparing for extreme events. And also a big topic is the real-time surveillance and evaluation of measures. This is actually where most of the cantons also said that they need support in that. So the target groups of the measures in place, shown here in blue for the cantons that have a heat health action plan, and in red for those who don't have at the moment. Besides the general population, the elderly population is the population group that most policies focus on. But then when we look at the cantons that don't have a heat health action plan, we see that many of the vulnerable groups, like there are no measures for these groups, like for example, children, people working outdoors, or people with specific chronic diseases. What support do the cantons need? Here again, shown for cantons with and without heat action plan. All cantons that have currently a heat health action plan, they need support in the evaluation. But when we look at the cantons that don't have a heat health action plan here, the support needs are more basic, so they need information material, they need some help in what measures they actually should take. And I have to say that all this material exists, also like specifically for Switzerland, but the problem, and that actually brings me to the barriers, is a lack of financial resources. So many cantons said they don't have the resources or the human resources to implement measures. And on the other hand, the success factors are motivated individuals, a political decision, and also motivation due to concern. Now, of course, the big question is, like, are these measures actually effective in preventing, for example, heat-related deaths? We haven't used this data for EPI studies, so I want to show just results from a previous study we did in Switzerland. We compared the heat-related mortality risk in cantons with heat action plans to those who don't have one. And we compared 2 time periods. The first time period is the time where they were like still under development, and the more recent time where they have implemented. And actually we found a significant decrease in heat-related mortality risk on hot days of 33 decrease in areas that have heat health action plan. But I have to also say, and you see that very clearly here, is that also in these cantons they had a higher baseline risk than in cantons that they haven't a heat health action plan at that time. To conclude, we see some progress in implementing public health measures on the level of the health departments in Switzerland, but of course there is still further action is needed. This survey provides a baseline for further action and also for future monitorings and EPI analysis. And in my opinion, and actually also 2/3 of the cantons, they are in favor of more coordinated actions between the cantons, and that is actually something we will work on in the future. Since this is a community-led solution and city science session, I would just to point out to our poster on Swiss primary health care, where we also include some city science methods. And now I'm at the end of the presentation. I want to mention that all the results and also some more results are published in a report on behalf of the Federal Office of Public Health. At the moment it's available in German and French, but it has also a summary in Italian and English. Thank you very much.
Thank you, Martina, for this wonderful talk. And you're very good at keeping time here. So, are there any questions?
Yes, hello, I'm Lisbeth Hall from the Dutch National Institute for Public Health and the Environment. And I think in a lot of countries we start at the national level, we have a national heat health action plan, and then we try and implement at the local level. So now in the Netherlands we have some 90+ municipalities with heat plans. But I was just wondering, am I correct in thinking that you don't have a national plan which is which the Federal Office has implemented, but you're starting at the cantonal level and then a national plan is coming? Is that
yes,
you're
exactly.
doing kind of the other way around, really? But
yeah. So we don't, at the moment, we don't have a national plan. And in Switzerland, it's like really the duty of the cantons who implement measure. The federal office, they can give some recommendation and can help in providing some information material, but then actually to implement measures is really on a cantonal level.
Yeah, so I'm just curious about the role of the federal office. So they are there to facilitate, but not to provide the knowledge base or anything like that. It's more just to help in the process. Is that correct?
Yeah, exactly. Yeah. Mm-hmm.
Thank you.
Thank you. Any more questions? We have time, so don't be shy. Okay, if not, then thank you very much, and we will continue. So now we will shift from institutional action to grassroots, community-led adaptation. Our next presentation is a joint talk by Anna Chavez, Dr. Anna Chavez from the University of Exeter, and Dr. Lee Towers from Deeside University. Anna is a medical anthropologist whose research focuses on how communities themselves adapt to climate extremes and how these adaptations influence health and well-being. And Lee is a social scientist whose work centers on energy justice, particularly how responses to the climate crisis shape fairness and equity in access to energy and in the outcomes of climate policies. So welcome.
Good afternoon. So we'll be talking about a community, we're studying community-led adaptation to climate change in the UK based on extreme weather events. And our teams from the University of Bristol, Exeter, Teesside University, Lancaster as well. So there's the names there. So we've been looking at, we wanted to choose particular extreme weather events, and we included cold, although that's maybe not always associated with climate change, but we believe it is in lots of different ways. It could just be that storms cut out electricity and people don't have the heating, and just that we're finding extreme weather events now include extremes of cold. And there's some useful slides there from the UK Security Agency we heard from this morning about some of the effects of flooding, cold and heat, for example, drowning, trauma for flooding, mental health, asthma from mouldy houses after they've been flooded. In the cold and heat, you've got a big impact on strokes and heart-related conditions and mortality. And there's almost endless, you could almost, temperature regulation and housing conditions impact almost all kinds of health conditions. So we wanted to look at what a community group's doing. So you quite often hear a lot about community adaptation, but what we wanted to really distinguish is that it's not about community level where government organisations or national organisations go into communities, or National Health Service go into communities and say, we're going to organise you, we're going to help you, we're going to support you. It's about what the community are doing themselves. What are they choosing to do? What are their resources? What are their what's their advantage that none of the government level organisations have? So that's what we wanted to look at, and also look at health, in particular health and social inequity. Just skip that for questions of time. So we did one little mapping exercise. We did a literature review, and we found that there's almost really just a handful of published literature on purely community-led adaptations to climate change. So we did a mapping exercise of grey literature, looking at social media, websites, and grey literature reports, and we found hundreds of examples of community-led adaptations for climate change, and we kind of categorised them a little bit here. Nature-based solutions for flooding, like slowing rivers, emergency response in the times of an extreme weather event, the organisation preparing for extreme weather events, knowledge sharing and the technical knowledge that they have, and resource sharing. and then just hand over to Lee for a bit.
So this is the kind of methods that we used. It was basically a quality method, and we spoke to staff, volunteers, project partners, attended events, interventions that the groups developed and implemented. We visited the sites multiple times and kind of communicated more informally. The cases specifically were these 3 cases. They were a mix of rural and urban cases with specific focuses on heat, cold and flood. So Loch Ken Trust was ironically a heat-focused study in southwest Scotland. And while they focused specifically on one thing, like the flooding in Meanwood Valley, if you know England, you can have 4 seasons in one day. So there's kind of a cross-cutting risks. They all focused on environmental justice and inequality. So Meanwood Valley Urban Farm and Loch Ken Trust, access to green and blue spaces for people that don't have this, and 361 Energy is working on energy poverty. So the kind of results were grouped into they were the kind of community level benefits. So you had kind of anticipatory and put my glasses on. Frontline responder role. So, for example, 361 Energy would provide electric blankets during cold spells. 361 Energy was also working as an intermediary in a complex system, so the fragmented energy efficiency funding landscape in England that's not really effective, and then the kind of energy poverty level at the ground level in the housing in Devon. All report going to the problems, all report funding problems, and there were kind of ethical problems and divisions and conflicts in the community. So we're going to skip this video because in terms of time.
We do have time, so.
Well, we'll come back to it at the end if we have time then. So in terms of the results in a bit more detail, these are the kind of specific results, and if we think about these results with Loch Ken Trust, they're doing a water safety program. Then they branch out into a community resilience workshops with local villagers in the area. These workshops both prepare by asking the communities, what do we need if X, Y, and Z happens? And then they respond by setting up a kind of command center, distributing resources during an emergency. And this takes kind of knowledge of the local people, the local infrastructure, the local kind of energy and kind of geography, and people who don't connect with public services. And as I said, both Meanwood Valley Urban Farm and Loch Ken Trust provide access to green and blue space. So back to you.
Yeah, but we found some fantastic things that they were doing on finding their own funding, but we also found they told us a lot of challenges they were having. And I don't know if anyone knows the politics in England at the moment, or the UK, it's kind of an idea that we can't have the government can't fund everything, so we'll let the community just pick up the pieces kind of thing. But it's not that simple. They are picking up a lot of pieces, but what they find is that they're often on very short-term funding conditions, and if they apply for funding, there's restrictions on what they can use that funding for. So they can't plan long-term. They can plan 6 months to a year at a time, and they can't actually develop projects. And if you're talking about doing preventative work, you need to plan long-term and have some stability. And they have maybe problems in capacity. And another thing they had was that, for example, Loch Ken Trust were developed because the local council withdrew the ranger service, the local ranger services. So they stepped in, they created their own community ranger service. And they were doing things like monitoring the speed limits on the lake, and picking up, kind of providing social services for vulnerable people. For example, someone who was found wild camping, and they understood that this person wasn't a normal wild camper. They found it by talking to her and gaining her trust, that she was actually somebody who was scared of going to court because there was a court case with her husband, a domestic abuse court case, and she was running away from it because she was scared to attend, and they supported her to actually attend the case and convict her husband in the end. So they were picking up all these pieces, but there's a limit because there's kind of legislative limits. There's there might be land ownership limits and legal limits. They can maybe find people who are breaking crimes, but they can't actually step in the full role of police. And yeah, so the biggest thing that keeps coming out was the instability, and that's based on funding and the need for the public sector organisations to really support them and not just say, well, we're going to consult the community, we're going to involve the community, but actually they need to back them and not just say, you know, tick boxes. Yeah, we consulted the community, we did a survey. This is like, they need to be supported to lead what they're actually good at leading and in the right place to lead. Yeah. That one.
So just to wrap up, no images. Hang on. Yeah. So when we're talking about resilience and kind of, we can also think about democracy. And evidence suggests fairer, more democratic societies with local autonomy are more resilient to shocks. Now, this is a graphic from Foxglove and the Global Action Plan, who are suing the UK government for they're kind of maladapting with their plans for AI, funding this, and this is the carbon emissions that will result from 10 data centres. They're planning 100. And this will wipe out the carbon reductions from electric cars. Added to this, research from Luke Kemp. This is a graphic from Luke Kemp's book. He's Cambridge University researcher on existential risk. If you look at this is a graphic of social collapse. And here, a lot of these things we have, then you've got the triggers, and then what happens afterwards. And I would argue that the way out of this is redistribution of wealth and power being the best option that we have. Thank you. Wait, sorry. We're not quite finished. Just...
Yeah, just to conclude, yes, so there's some... we need to appreciate that local knowledge is valued. It's not second-rate knowledge. It's just as essential and valid as scientific knowledge or knowledge generated by in a professional levels, and understand their essential role as intermediaries between government agencies and the community members because of the trust that they have. And we need to acknowledge the challenge they have and listen to them and to see how we can support them a bit better. And so we've finished this now. We're about to submit our paper for publication. We've submitted the paper on the literature review as well. We've now got some funding to do a phase 2. So with this one, we're focusing less on the organisations themselves, but more on the people, the community members. So we're looking at, we're going to do ethnography of people learning difficulties based on the same topics, and school children in the Loch Cairn area, and community members that are vulnerable to cold in the Devon area. And if we've got time for this video, I don't know if we have.
How long is it?
It's, I don't think the clip will work because it's...
You can try.
Yeah,
this
will it
was
work?
a resilience kind of rehearsal. They did like a live resilience workshop. We pretended something happened, and then the community worked together on it. We attended this, Anna and I.
With the link, no. What you could do is you can scan that and you can watch it in your own time. It's a 3-minute video that the local TV station went in and looked at what they were doing locally. Thanks. And the people that we interviewed were on that thing. There.
Thank you very much, Anna-Lee. Are there any questions? No. Okay, we can take some questions at the end if people can think about something to ask. So now we will turn to another form of community participation, citizen science and creative collaboration. Our next speaker is Dr. Nuria Castell. She is a senior scientist at the Environmental and Climate Institute in Norway. That's right, is it? Yes. And there she leads the Technology and Society Group. Nuria also coordinates an European project that integrates citizen science and creative collaboration into urban environmental research. Today, she will present examples from projects where citizens and artists work together to monitor air quality, heat and noise, and to translate their environmental data into community dialogue and collective action. So, welcome, Dr. Castelli.
Thank you very much. My goal today will be to convince you, to inspire you to start working with creative and artists in your projects. And maybe some of you may wonder, okay, we already have a lot of data to analyze, important reports to write, and on top of that, do we really need to work with artists? So, wait a second, here. I think this picture illustrates why. So you can see in the screen here, this is how we usually represent air pollution data. And actually, I thought this was a nice visualization. We have here in this square, no, it doesn't work. In the square, we have like what we call like an air quality index, and it's green if the air quality is good, it goes yellow if it's moderate, it goes red and purple if the air quality is very bad. And then we have numbers illustrating like what are the concentrations, the temperature, the relative humidity. And then you have here, you see the face of this kid? Yeah, that says all. So if you are a non-technical person or not familiar, that's the face you put. In 2017, I was approached by an artist, it's Michael Pinsky from London, and he had an idea about creating some domes where people could walk in and then experience the air pollution from London, New Delhi, and also a clean area in Norway, where the air pollution is pristine, where the air quality is very good and the air is pristine, right? And first of all, I had to convince him that it was not possible to bring pollutants and deliberately expose people to those pollutants. So we had to recreate. And then we work together on recreating these atmospheres and these domes. And then actually he made it. And those domes, this installation is called pollution pods, and they are have been mounted around the world, and it gives you this consciousness, and suddenly you can walk from areas to areas, and the good thing is that you can embody and feel how air pollution that is invisible, you actually start walking to a dome, and then you feel like, I feel oppressed, I cannot breathe. You know, and also like how it affects your emotions. I feel like more anxious, more anger, right, in atmospheres that are oppressing. So that's a good understanding, right? Like, and the people comes out of the domes like kind of like more with a higher understanding of the importance of the air we breathe. And now I would like to walk you through three projects that I've been participating. Where we have a mix of citizen science that will be like engaging with the community and the people, also in the monitoring of the environment, in understanding the data, but where we also start working with placemakers, creatives, and artists in then bringing some of these solutions into implementation. So, I'll go one behind. So this co-mobility project, co-designing inclusive mobility, was about the use of private cars. And here we decided to focus on the use of private cars around the schools. And this is like parents driving kids to and from school. So we work with 3 schools in Warsaw, in Poland. And here you have pictures of the children. We installed sensors that were monitoring noise and air pollution, and also like the children around the schools themselves. They had also monitoring campaigns, and they were monitoring the speed of the cars. They were monitoring also the time that the green light in the crossings stays on. You know, and compare like how long it stays for cars and how long it stays for people. And also they did a monitoring campaign with monitoring NO2 and PM2.5. The data was presented then also to the city council that took measures into place. And we saw, for example, on the noise, that's the blue line there, that the schools that are really nearby the roads, the noise levels exceed what is recommended. And also we saw on the pollution levels, both in PM2.5 and NO2, that levels during good part of the year, especially during the winter, exceed what is recommended for health protection. So, but we did not stay just there on the data space. So we came back together with the children, you see them there, in evaluating the space surrounding their schools, and then they co-created solutions that they wanted to see implemented. And some of the children went for designing a magazine, and they make it to life. Another ones decided to do a garden in their school that will be a place where they can be away of noise, but also like they had this idea that the garden will clean the air they are breathing. And other schools that were nearby, very trafficked roads, they said they didn't want to say that, walking to school was too boring and the streets were boring and plenty of cars. And then we worked with a local artist on creating these games where they will find crackers, and then they will find like motivational, like you look good today and things like that. Also, the children designed this statue that they wanted to be, that there was visible from the road, and then an artist put it into these girls on scooters to call the attention. And one of the things we also did with an placemaking foundation in Warsaw was to get inspired from Bogota city, where they had memes directing the traffic, and we had that also during some of the mornings where the memes will be there dressed and congratulating the people that stop at the pedestrian passes, etc. So it was a really nice project, and really from the people that is affected by that is the children. Another project was MCLIC, where it was about embodying climate change. And here I will present the work that we did with the anthropologists, also on working with older population on how their daily lives are affected by climate change, and especially from heating. So here we also we did a citizen science approach, where we use like a temperature measured by the citizens in the cities of Warsaw. That's more crowdsourced. It's like that data that was already available, and mix the data together with already existing data sets and satellites to create maps. You can see a poster below. But also we instrumented, give to these elderly people like sensors to monitor the temperature while they were in the city, walking, doing their daily activities, and also when they were at home, and then mix what the data that we are getting from the sensors with the data from their perceptions to better understand these differences and how they are adapting. But one of the things we realize is that it is not so easy to go from data and temperature to actually what is your body experiencing due to that temperature. And here, like we We co-created together with the people. Here you see some pictures of them. What we were using was, together with another group of actors, like drama techniques, where they were like like feeling like, okay, like you can see that they are wearing hats and sunglasses. It's like, this is a very hot day, how I feel. They were also doing drawings and having in their bodies, like where in the drawings, where the heat is affecting them. I'm sweating, I'm feeling headache, I cannot go out. And then, like in Madrid, the 10 older people, they also participated in creating a film, and that was then showcased in different film festivals. It's called The Wave. And they participated there and also showcase how is their daily life, how is affected in a day in Madrid with very high temperatures. And then we finally also did a game jam where we got people from the university to create a game based on the results of the project. And if you think that maybe taking and talking with participants is very difficult, in the City Ops project, we have been working in tools to help practitioners and observatories to make this into practice. So here we are already working with 35 observatories monitoring heat or air pollution and bringing their data into maps that then can be used for policy. But also, we have created these toolkits with the Fab Lab Barcelona, where you can see there how to implement, how to start working with creatives, how to start making community-led actions with the people in the place. And this is some images from the Barcelona, so you can see. And I would like just to finish, art has always been to work among us. And this is some examples from the old times, like Monet, and also new art installations. Thank you.
Thank you, Nuria. One very quick question, if there is one.
Yeah, thanks very much for the inspiring presentation. So we should follow you and do more art in our actions. So can you just elaborate a bit on the installation of the air pollution domes you did some time ago?
Yeah, you can also see on the website of Michael Pinsky where the installation are done and how they can do. I'm not sure, I think probably but we can talk after. So I'm not sure what you mean by elaborating more, but yeah. So it's the installation is floating. It's just going around different places.
So for our final presentation in this session, we move to the Eastern Mediterranean context. Our speaker is Alex Pau. She's a doctoral researcher at the University of Haifa, and Alex's research examines climate risk, vulnerability, and adaptation among Arab Palestinian citizens of Israel. And that includes a participatory case study, and I think she's going to speak about that. So welcome.
Thank you for the introduction. So I'm pleased to be here today presenting on behalf of myself, my colleague Ala, and my supervisor Maya, who's here and presented earlier today if you saw it. Okay, so actually I will not talk about our participatory research because this study is part of a broader participatory research that took 3.5 years, but this specific study is a nationwide survey, a quantitative survey, but I can tell you about the participatory research in the break. So in this survey, we looked at willingness of individuals to take individual level, household level climate adaptation measures, and looked at the association between this willingness with self-efficacy, outcome efficacy, and social norms, as these are factors that have been found to have larger effects in previous studies, but there are fewer studies considering these different variables. A little bit about the survey population, because it might not be clear to everyone. When we talk about Palestinians in Israel specifically, so those are mostly Israeli citizens, making up about 1/5 of the Israeli population. We're not talking about the occupied West Bank or Gaza, where we hope that things will get better. And most Palestinians in Israel live in Arab localities, cities, towns, or villages, which have, in general, lower socioeconomic status due to historical and structural discrimination, mostly. So we asked people in this survey whether they were willing to take a number of measures, and 4 in particular. First, we asked if people were willing to plant a tree in the yard. That's for people who had a yard, positioned in a way to also provide shade to the public street. Not just to their own yard. We also asked people who had a yard and who said that their yard was mostly covered by impermeable materials, whether they're willing to change their yard cover so that, to help prevent risk of floods. There's not a lot of rain most months in Israel, but when there is, sometimes there's very heavy rainfall with some flooding. Something to mention about this one and the previous one, these measures, they require large-scale implementation to have impact, right? And that's why it's particularly interesting to have also the contribution of households and not just the municipality to reach that scale, especially since in Arab localities, there's also much more private land than municipal land. We also asked them, so there's, in Israel, the sewage system is separate from the rainwater drainage system, and technically it's illegal to connect them, but there is a phenomena where some people will connect their rainwater gutters to the sewage system. So we asked people if they were connected, and if they were, whether they were willing to disconnect them to prevent sewage overflow. And we heard that climate adaptation is not only infrastructure, it's also social. We asked about whether they would be willing to join a climate volunteer team to support vulnerable residents in emergency situations. So this survey was distributed by telephone over about half a year last year. We have a representative sample in terms of gender and geographical region, whereas in terms of age and education, the respondents are somewhat younger and more educated, but close to representative. I'm just going to pass this for time. We asked about level of concern regarding different hazards, climate and non-climate related hazards. In terms of climate-related hazards, the rate of respondents who responded reported being very worried ranged from 10.4% for wildfires to about half for extreme heat waves. That half is similar to concerns regarding economic situation, like poverty or unemployment, but much lower than concerns about war, but also concerns about violent crime. There's a real epidemic of violent crime with criminal gangs, and so that was the top level concern. We asked also whether people had experienced negative impacts of climate-related hazards, and more than 40% reported that they experienced at least some negative impacts from at least one climate-related hazards. For heat and extreme heat, those impacts were more health-related, and for heavy rainfall or floods or sewer overflow, they were more financial. And then, so looking at the core question in the survey, willingness to take climate adaptation measures. So we asked about 8 measures, not just the 4 that I mentioned. And for 7 out of the 8, more than half reported that they were willing to take this measure. Of course, there may be some bias because it's a theoretical question. but we can see clear differences between different types of measures. The highest willingness was regarding planting the tree in the yard, and the measures with the lowest willingness were more political, signing a petition towards the local authority, and during elections, checking whether candidates consider climate change in its impacts and proposals. I have comments about that, but not for right now. So for each of the 4 measures that I talked about, we asked a series of questions to measure perceived outcome efficacy, how much people thought that these measures would actually be efficient at doing what they were targeting to do, like preventing floods or reducing urban heat. Social norms, whether they thought that people would agree that these are good measures to take, and actually almost consistently for all measures, the lowest score was for whether, if I think that people in my community, others in my community will take this measure. And also self-efficacy, how much people thought they thought they were capable of taking these measures. Here, this summarizes a little bit, and I see that the color is a little bit light. Is there a, no, okay. So essentially for the height of the bars shows the perception for each of these different scales. And the highest for all of them was outcome efficacy, which suggests that people in general, they agreed that these measures, would be good to implement and would be efficient, at reaching the goals. And the lowest was social norms, as I mentioned, specifically whether others would, but also social norms in general. And then we also looked at the strength of association between these different variables and the willingness to implement the measure. And for those, it was self-efficacy that most consistently had a strong association with willingness to take the measure, as well as social norms. This is just bivariate analysis. We're going to do multivariate analysis. But so, perhaps unsurprisingly, considering behavioral models, the belief that you're capable of taking a measure seemed to be most strongly associated with people's willingness to take it. Some recommendations based on these results. First of all, there was a very high willingness for several measures. Including the volunteering measure, the trees measure, and we also see this in the field. So local authorities and authorities in general can really leverage this existing willingness. The second thing is they may want to focus on measures that enhance self-efficacy. One thing, for example, with regards to the rainwater gutters that are connected to the sewage system, authorities want people to disconnect them, but there's no information on how to do that. There's no, guide, there's no pilot program, so that's something they may want to consider. And the third thing is, this whole survey looks at what households can contribute, and I explained why that was relevant. But at the same time, still, local authorities and they'll need the help of the national government, considering lower socioeconomic status and so lower capacity in general. Local authorities need to do these things in the public space as well. And this can, not only will that help, in terms of the measures, but it could also have a positive impact on those social norms, when I'm not only seeing people in my community potentially doing these things, but also seeing, the local authority doing these things. So I just want to say thank you very much to all the team members in this study and in the wider study. It's a privilege to work with them.
Thank you very much, Alex. Is there any quick questions? Okay, if not, then thank you again. And thank you for all the speakers for your thought-provoking contributions, and thank you for listening. Have a continued nice day.
Is this on? Oh, yes. Great.
Yes, I just.
Yeah, but we were wondering, how does this work in order to advance the slide? The remote.
Yeah, if it's
What do you press?
next and
Next.
previous.
Next, the big button is next.
Yes, previous is this left side. And if you are doing previous, when you introduction, I would go.
Great. I think we will begin. Welcome, everyone. I'm very happy to see this small, exclusive crowd that you're like still holding on. It's it's been a very long day, but it's been full of impressions. I have learned a lot. And today in this session, we will have presentations from people really working on the ground, and we will be discussing how can we move from evidence to action in building climate resilient and sustainable health systems. So I have with me colleagues from the Norwegian Red Cross, and sorry, my name is Thea Holten. I'm a climate advisor at the Norwegian Red Cross, and I will be moderating this session today. So we will be hearing presentations from the Norwegian Red Cross and how we work on strengthening climate health systems. And we will also have colleagues from representing Burkina Faso and also Ukraine, and then the Norwegian Public Health Institute. Each one of them will be holding a presentation, and then we will have a short panel discussion and also open up to questions. And since we're a fairly small audience, I really hope that we can have some interactions. I think that's really, really important. And we have people now who are like really working on this day to day, so we can really share some of their experiences. And this is a great chance to be asking questions and to be engaging. So to begin, I would like to ask Claudia Vivas Torrealba, who is a senior advisor for health and climate at the Norwegian Red Cross, where she leads the implementation of our organization's strengthening and climate resilient health system approach. She provides technical support to country offices and national societies to advance climate resilient health systems globally. So please, Claudia, the floor is yours.
Thank you, Thea, and thank you, everybody, to take some time to listen some experiences from the field. And what do we do with all the research that you actually produce? We are not researchers, but we work in close collaboration with academia and with all the actors that work in health and climate. And for doing that, we need to remind ourselves why is this relevant and what is going on. And actually, this slide is not as updated as it should because we don't have that much data yet. But what do we know is that, in a nutshell, everybody talks about health and climate, but resources are not put into health and climate action, especially in the field. And we have evidence from the UNFCCC. We have a lot of reports. All the reports from the COPs are saying every year that there is not enough money. Only since the last COP, health is finally part of the agenda officially, so hopefully that will also leverage more funding to work on health and climate. And what is very important for us working at the Red Cross is that more than 2 billion people live in countries with fragile, conflict, or violent settings. And of these, 134 million needs humanitarian support. And that includes providing accessible help. And do we know also how war and conflict also creates and contributes to climate change? So that's why it's so at the core of the agenda for us in the Red Cross. And for doing that, it's even not easy for us to put everybody speaking the same language. So even an organization like the Red Cross that's all the time talking about health, we had to remind ourselves, what does it mean universal health coverage? What does it mean strengthening health systems? What does it mean primary health care? Because this is the niche in where we think we can work and make a difference. So, well, you know, universal health coverage basically is that everybody obtain the services they need without suffering for paying for them. But we should not forget that it's not just about financial protection. It's also to ensure that we have quality of care and that we have access to all the commodities that we need to do that. So it's really a comprehensive approach. And health system strengthening are all the strategy responses and activities that are designed to sustainably improve the outcomes in a country. And where we can deliver that the best, this is what it's said in every conference, and what we know is primary health care. That's really the gold stone for ensure that we could eventually maybe achieve universal health coverage. But when we work in an organization that is so service delivery driven, we tend to forget that primary healthcare is not only the clinic, it's not only the primary healthcare center, it's the communities, and it's also all the work that we do multisectorially. In the case of the Red Cross, we were very close on protection issues, waste sector and other sectors. And all these really convene at the primary healthcare. Now, we have global frameworks. So our role from the Red Cross is not to develop new frameworks or new tools, but try to see what the international community agrees and how that can be adapted to do the interventions we have. So we are familiar with this. I saw it in many posters earlier today, but basically, that's a lot there. And when you talk to practitioners on what's going on, it's not that easy to adapt. So we have the regular building blocks that whoever knows in health knows they by heart: human resources, supplies, financing, leadership and coordination, service delivery, and health information systems, and then how they are disaggregated in the WHO operational framework. But when we did our consultation, trying to talk to people that come from different backgrounds, different sectors, even within health, it's not the same to talk to an emergency person than to somebody that is working on health systems. So we have to go back to the basics. And in order for us to do that operational, it was just easier for people to understand what can we do from the service delivery, for the health workforce, etc. And what you see there are the different kind of activities or actions that we believe from the Red Cross we can support countries towards strengthening the system and working in this way. And we're going to see some examples later, so I'm not going to stress too much on that, but I think it's important to remind that. Being a humanitarian organization is also very important that we understand what does it mean to support the system and what does it mean to strengthen the system. And as most of you are researchers, I really invite you to read this paper. This paper has like 10 years. And basically, it came when we have all the driven around the world to work more on vertical programs, but everybody was having a health system strengthening program. You have Gavi HSS, you have Global Fund HSS, etc. And the findings for that is like, well, we are saying that, but we are not really strengthening the system. We are working only in immunization, or only in HIV/AIDS, or only on TB. So why is this important? Because especially when you work at short-term emergency, we tend barely to support. Why? Because we also need to save lives. So at a certain moment, you just need to distribute mosquito net and to vaccinate people. But when we say that we are strengthening the system, we need to go beyond that. And we basically need to permanently make changes in the system. And for that, there are some criteria that were presented in this paper and that we actually adapt to what we do as the Red Cross to make it very simple. Because health system strengthening is not about building universities and have 1,000 doctors from one day to another. It's how health system can be strengthened in everything that we do, even if it's in a specific project. So we say, well, we need to have cross-cutting benefits. That means going beyond single diseases or vertical programs. We have heard today a lot of things on dengue and heat, but we need to remember that we have multi-hazards, and we need to consider, because people are not having only dengue. Most probably there will be a heat wave, and most probably there will also be a diabetic person there. So we need to ensure that we have a multi-sectorial approach to that, and that goes beyond one single vertical program. Then, of course, we need to ensure that we are working about the functions of the system. What are the functions? Are the supplies, are the human resources, is the service delivery, the health information systems, and the leadership and governance. And for doing that, we ensure that we are considering all climate hazards in the places in which we are working. Then to produce permanent impact, even if it's a project only of 3 months, we need to ensure that this is then embedded into either a local or a national initiative so it can be carried on. And then that we develop or have knowledge exchange of the capacities. In our case, our main we are all national society, so it's really trying to see how the Red Cross capacities can be improved, but also other actors that we work with, like, for example, the Ministries of Health. There are just few examples here. What does it mean in practice? And I will maybe go only to one of them. Everybody says that they are doing training, and when they are doing training, they say, we are strengthening the system. Well, no. If you just do a training for picking the finger to take a malaria rapid test, this is not strengthening the system. This is only addressing one gap that who knows how we're there. But we can say we're strengthening the system when we have a plan, when we have met with the different stakeholders, and when we know that doing the prick in the finger is important, but this is embedded. We have peer supervision, we have follow-up, maybe we have curricular revisions, and it's part really or something broader than just one-go training. And like that, there are many examples. When we talk about generators in health facilities, if they are only used for the cold chain, then, well, we need to think twice. We need to see, are there other programs that benefit from that from maternal and health? Like, for example, the oxytocin for the pregnant woman, if it's a facility that is taking care of it. And although we are not a research institution, we try to document what we do. And what we did last year, actually, and that was presented in the Attach conference last year, was to see how are we really applying these interventions in different contexts. So we took the example from the Americas, Pakistan, and Somalia, completely different context, but all of them managed to put that into place. And the lessons learned is nothing new. We need to leverage the local knowledge. We need to have a multi-sectorial approach and coordinate beyond health. And we also need to have decisions that are evidence-based. And that's why for us it's so important to be part of this forum and to hear from you what's going on in the latest research. This is just an example, I'm not going through it, but you know the Red Cross works a lot on emergency response, and we normally did not need a contingency planning for that. And this is a great example how we can apply this criteria to ensure that we have a solid plan that then can be operationalized when we have a contingency. And finally, I wanted to bring to your attention that as we are not researchers, but we read what you do, there was actually a very good revision, and I think this revision was maybe done like 2 years ago from a university in South Africa, in which basically they went through a systemic review to check what are the knowledge gap on health system strengthening at primary healthcare. So we do know what needs to be investigated, and in our case from that revision, we selected the ones that we thought we could contribute or work together with other partners when we are going into that. Because as the Red Cross, being the humanitarian organization with presence all over the world, we get a lot of requests from everybody to partner with us to do research. And we also need to be a bit more systematic where do we engage or not to ensure that we are actually fulfilling and trying to contribute to strengthening the health system. Thank you.
Wonderful. Thank you so much, Claudia. And so moving from the work of the Norwegian Red Cross, we will be traveling to West Africa and Burkina Faso. We are very glad to have Didier Bella here today. He's a qualified medical doctor and public health specialist who has worked on several projects across Africa. He has contributed to the development of several community-based approaches and strategic documents, particularly in the field of health within the Red Cross and Red Crescent movement. And you are currently based in Burkina Faso, working as the country representative for the Norwegian Red Cross. So please, Didier, the floor is yours.
Hi. Sorry. Hi, everyone. I want to start this presentation by to apologize on behalf of the representative of Ministry of Health of Burkina Faso, because I'm supposed to come here for this conference, but unfortunately, because of administrative issue, he's not there. So it's not the result of research, but just to show you what we have done in Burkina Faso. So let's present the context of Burkina Faso. It's a silent country in West Africa, facing multiple security and environmental challenges. And now, since 2015, we have an armed conflict in this country, which has displaced over 2 million IDPs. And this complex situation significantly weaken health infrastructure and exacerbates the population vulnerability to climate change. So what's the profile of Burkina Faso in terms of climate? What's happened here? Maybe it's wave, we don't know. Okay, it's a silent climate, as I already said, and we have a tropical and dry climate characterized by a short rainy season, only 3 months, June to September. We have extreme temperatures, the annual temperature of 32 degrees with variation from 17 to a maximum of 45 degrees Celsius. We also have a accelerated warming. So we had now a significant increase of temperature since 1960. And in 2024, the country recorded 5 heat waves between March and May, including 4 daytime and 1 nocturnal, illustrating the intensification of extreme climate phenomena. So we can see there the different type of vegetation we have in Burkina Faso. Desert in some part, and yeah, we can have some trees in other part of the country. So in this country, the major climate hazards, we have drought, period of water deficit affecting agriculture and access to drinking water. We also have floods, even if we have a short rainy season. We also have heat waves and winds. These climatic phenomena characterized by the increasing intensity and unpredictability directly threaten public health and the stability of the health system. So in Burkina Faso, we have this major climate hazard. And obviously, this have an impact on health, increasing mortality, emergency in disease, and the destruction of the system. So this health impact demonstrates the urgency of adapting health system to changing climate reality of the Sahel, mainly in Burkina Faso. It's clear we have this climate impact, but also the conflict has also an impact on the health. So now we have around 2 million person IDPs, 31% of health facilities affected by this conflict, of which 17 are completely closed, and more than 2 million of people are in need of health assistance. So the combination of security crisis and climate challenge creates a particular critical health situation. So what are the key challenges identified? Insufficient awareness we realized that among the population, there is a lack of information about heat wave and the preventive measure. We also have a limited prevention because of during the heat wave period, and the infrastructure are not adapted to deal with the climate change. And in terms of training, the capacity of the health professional need to be strengthened because of the adaptation of the training at school and now the new trend as climate change. So we have to build the capacity. We also have some challenges in terms of coordination, because coordination among different sectoral stakeholders remain inefficient for climate impact prevention and mitigation efforts, because we have a lot of stakeholders involved in this response. Means your health, means your environment, but unfortunately, it's something which is seem news because of the past. So they have some lack of in terms of coordination, and we have lack of harmonized protocols, and also lack of resources. And so we also have a adaptation capacity. The health sector requires significant strengthening of its adaptation capacity to climate change. So we have to revise everything in terms of vector-borne disease prevention strategies, waterborne disease control, and also institutional resilience. But we have strategic opportunity. At the government level, we have a commitment of the government which has a plan of national heat wave, also a national adaptation plan, and they also have a center for sanitary operation and emergency response. In the movement, we also have a sort of partnership, an active engagement of the Burkinabe Red Cross with an early action protocol for heat wave and a dedicated climate change program, and also international cooperation. This one, for example, which is an opportunity, as I'm speaking on behalf of Ministry of Health, we're supposed to present this, for him, it's an opportunity to have this conference, because he can have some relationship with the others to strengthen activities in Burkina Faso. What have been done and what is initiative are ongoing? The first one, health system strengthening. Now, at the level of Ministry of Health, there is a development of a pool of trainers specializing in climate change and health issues. As I already said, we have to adapt the curricula to include the climate change aspects, to be sure that at the health facility, doctors will be able to deal with this new situation. We also develop training and communication materials that can be used for health agents and also for community health workers, and also development and implementation of climate change and incident action plan, the first one. Since last year, they realized that there is a lot of demand of care at the health facility related to heat wave. So this year, the Ministry of Health decided to have this plan to respond. So it's the first one in the country. At the community level, we're also training community health workers on the health impact of heat wave to allow them to do awareness campaign through home visits, radio broadcast, and discussion group with community level. We also have strategic support in terms of development of strategic documents and organization of planting days, support the Ministry of Health in raising funds because we have a lack of resource, experience sharing to develop partnership, integrate climate change consideration into the Red Cross routine activities, because something very important, the volunteers of Red Cross have their routine activities in terms of awareness activities, and now in their training, we include climate change aspects. Also at the Ministry of Health level, they include package information into the call center. This initiative demonstrated the concrete commitment of local stakeholders in building a climate-resilient health system. but concretely, what have we done this year? So the first thing that the Ministry of Health decided to do to address climate change issue is to organize a workshop with all the stakeholders, with the active participation of the Red Cross in the development of key messages on heat wave. So the content developed by the Red Cross served as a reference base for the Ministry of Health. The Red Cross developed some key messages and some communication tools that the Ministry of Health used to develop their own messages. I don't know if I have time to show you this, but we have the link here, but maybe later. And at the end of this workshop, they realized key messages, they printed materials, communication materials, and also communication tools. Those different elements have been used by the community health worker and the health agents to work. But during these activities, we had a tripartite supervision involving the CORIS, the Center of Emergency Response Operation, the Ministry of Health, and the National Society, I mean the Red Cross. So they use the different tools to train volunteers, and at the end, they were able to implement awareness activities. So at the end, for this year, 19 staff have been trained in climate emergency intervention, and on 250 Red Cross volunteers and community health workers have been also trained to do awareness activities to reach, at the end, 49,000 people, including vulnerable group, elderly people, pregnant women, and albinos people, and also refer people to health center for appropriate care because of some issue with them. The next step is to make sustainable the different programs. So we have to institutionalize the development module and ensure the integration into national continuing education program and also in cerebral training program. So it's not only to have a training, but it's to have this in the system. So we have to adapting curricula of training of at the Ministry Health level. We also have to have, as Claudia already said, a cross benefit beyond a single disease, and also strengthen government leadership, particularly that of Ministry of Health and National Society. The second point is the expansion of the network, and the last point is to have evaluation of what we have done. So for us, intersectoral collaboration remains key to the success of a resilient and sustainable community and health system. So at the end, thank you to our partners, and yeah.
Thank you so much, Didier, and thank you for sort of representing the National Society of Burkina Faso and the Ministry of Health, who unfortunately couldn't make it here today, but I think it's still very inspiring to hear some of the, or a lot of the work and progress that you've done in a very fragile and complex context. And with that, we will be moving ahead to Ukraine, and we have our colleague, Dr. Vyacheslav apologies for your name, Tolkovanov, yes, coming from the Ukrainian Red Cross. He is a legal and public administration expert with over 2 decades of experience in government, academia, and international organizations. Currently, he leads the Companies and Association Relationship Support Department at the Ukrainian Red Cross Society, where he oversees key health sector initiatives, including professional education for nurses and digital learning platforms. Thank you so much.
Dear colleagues, ladies and gentlemen, friends, I have the pleasure to present today the experience of Ukraine, in particular of the Ukrainian Red Cross Society, in building climate resilient health system and communities, in particular in this crucial time for my country, the time of the ongoing war. As you know, Ukraine is the largest country of the Europe, at least of the western part, of the eastern part of Europe, and now Ukraine has been living through the combined impacts of the armed conflict, climate change, and social vulnerability. And these crises are combined, and they all deeply affect the health and well-being of the population. Doesn't work.
Air alert. A missile will destroy this house today. Will destroy this school, kindergarten, maternity hospital, air alert. People are in the basements of their houses, who are not lucky enough in their yacht. Some are buried underground, some under the rubble. There are hundreds, thousands of them. The war is still going. And the Ukrainian Red Cross is still helping. Air alert. Get ready soon. It will be necessary to dismantle the rubble and look for survivors after the missile attack. We will have to load the car with the boxes of food and water. Go to those who are waiting for us. It doesn't matter whether there are broken bridges or roads strewn with mines. We chose this way of life by ourselves. None of us have the thought of stopping. There is only the desire to stop the bleeding of a person injured by a missile fragment. To get the child and mother out from under the rubble of their apartment. Take the grandmother who can't walk but really wants to live out of the chili. And the one who still doesn't want to be assured that her life is valuable, that she is our family, that our care awaits her in the evacuation. They are all relatives to us. Therefore, we are ready to ferry them across river, even under fire, to equip convoys of vehicles to save everyone. As with relatives ready to share their pain.
Светочка, вам из дома не хочется уезжать?
Не хочется. Не хочется. Это будет отпуск.
To comfort.
Не хочется со Слуганска уезжать, не хочется.
Hug. Find words to give hope that everything will be fine when they are no longer believing it. They are all relatives for us, wherever we are, and we are there where there is a need for us. In Kharkiv, when you have to shield a person from rocket. In Lviv, where women and children who were forced to flee from these rockets will be searching for shelter. In Chernihiv, where we are building a new home for those who decided not to leave but lost everything. The main thing is to stay alive. When some wounded are alive in Kiev, because we are taking a generator to the hospital so that there is light in the operation room, and without light we applied tourniquets to a woman in Kherson after missile attack. After the missile attack, we deliver building materials to repair walls and roofs in Kuhar so that people do not leave their own homes. We console those who had to drop them in order to get on the evacuation train to Zaporizhia. In Zaporizhia, we are giving our humanitarian aid to those who have experienced disaster. We are among the first ones who go to the liberated cities and villages. Air alert. Get ready soon. The war is still going. And the Ukrainian Red Cross is still helping. They are also shooting at us. Our volunteers, our friends are dying. But we stand. And you stand by us.
No one can fully prepare for war, but it's vital to learn from what we have been through. These lessons cost us dearly, and today we are here to share them back with you. We stand by you.
As you can see, the armed aggression of the Russian Federation against Ukraine has severely affected the population's health and the functioning of the healthcare system. And now the full-scale war in Ukraine enters its 4th year. And an escalation in hostilities, destruction, occupation of settlements in frontlines areas of the war, coupled with massive aerial attacks, in particular now, against, in particular, energetic infrastructure in Ukraine. And as a result, an estimated over 13 million people are in need of multi-sectoral humanitarian assistance in 2025, and according to the UN agencies, over 4 million people remain displaced inside the country. And we can say that this is the most important humanitarian crisis in Europe after the Second World War, in particular ongoing conflict. And in these circumstances, Ukrainian Red Cross Society is supporting government-led recovery efforts, and in particular, emergency assistance. Therefore, of course, it's difficult to say in this context about climate health approach presented today by different speakers, but it is still in our mind, because we are preparing the recovery of the country, but I can repeat that the most important things today for us is winterization plan, preparation for the winter, despite of Russian attacks against our infrastructure. Of course, to respond, to prepare evacuation of the population in the frontline areas, and of course to provide emergency assistance. However, I would like to touch
Air alert.
Sorry, it might be another slide. No. How to? Could you help me, please, just to? Yeah. No, it might be a little bit. No. The next slide, please. Thank you. And just to pass very briefly through some important challenges in the field of climate and health the country faces frequency of extreme weather events, floods, droughts, heat waves. There are some statistics on the slide. For example, floods affect over 600,000 people annually. Heat waves are becoming longer and more intense. Air quality continues to deteriorate due to industrial pollution, etc., etc. However, Ukraine receives the chance to become a candidate to EU accession. Therefore, on the different levels, we tried to approach EU standards in the field of climate and health protection, despite of the Russian invasion, Russian aggression. And first of all, Ukraine has already adopted a few important initiatives, legislative acts, recommended by the European Union. In particular, I would like to mention some key legislative acts in my presentation. And first of all, EU's Ukraine Facility Plan, approved by the European Union, European Commission, until 2027, includes over 50 billion of Ukrainian hryvnias to support climate-related reforms and investments, ensuring compliance with the EU standards and facilitating integration. Ukraine remains active in international climate processes, fulfilling its emissions reporting obligations. And of course, Ukraine is going to prepare post-war recovery with special focus on climate protection and reinforcing national health system. In this regard, key goals of Ukraine's climate policy you can see on the slide: decarbonization, renewable energy, emission reduction, energy efficiency, climate adaptation, environmental restoration. In 2024, the Parliament of Ukraine approved a very important law on the basic principles of the state climate policy. Very important law to approach European standards and to prepare the national strategy until 2050. And key aspects of this law: climate neutrality goal, EU alignment. The legislation is designed to implement EU climate legislation and other normative acts, strategic planning in this process, cross-sectoral framework, post-war recovery, and climate governance. And just to mention that in June 2024, the Cabinet of Ministers, the government of Ukraine, has approved the National Energy and Climate Plan until 2030. At the same time, regarding Ukrainian Red Cross Society response in this field, we can say that we mobilized over 7,000 staff members and 10,000 volunteers across all regions of Ukraine to support our initiatives in the field of health protection. And key actions include home-based health and care services, psychological and psychosocial support for the most vulnerable categories of the population, displaced families and others, in conflict-related trauma, for example, rehabilitation and recovery programs for the target groups of the population, community-based health education, and supporting the green healthcare infrastructure. And our objective is to build climate-resilient health system. In this regard, some current initiatives, just to mention, mapping health vulnerabilities to extreme weather, developing early warning systems, supporting the transition to energy efficient and low carbon health facilities, and promoting green spaces and community centers. Maybe just to mention some initiatives, state initiatives in the field of the implementation of the state health policy. According to the recommendations of the European Union, the government of Ukraine approved in January 2025 the new Ukrainian health system, the National Health Development Strategy until 2030. This recommendation was a key element of the European EU Commission enlargement report for Ukraine, and we successfully realized this task. And key goals of this national strategy will be to strengthen intersectoral coordination of the implementation of the state health policy, to develop and to realize the potential, the resilience of the national system, and to implement universal access to high-quality healthcare services. And this strategy will serve not only for the recovery, I can repeat, but also to align with the key EU standards and requirements in the field of health policy implementation. Key areas of focus will be primary health care, digital transformation, human capital development, investment attraction, integration with the European standards, and readiness for challenges. And we hope to create innovative and open for challenges system. However, we could say that some very dangerous events, in particular destruction of the Kakhovka hydroelectric power plant dam in June 2023, and now very dangerous situation around Zaporizhzhia nuclear power plant, create some risks, not only for health system, but in general for the security situation in Ukraine. Because just to mention that Zaporizhzhia nuclear station now, this is the largest nuclear station in Europe, not only in Ukraine, but in Europe. This station now is occupied by Russians, and now it's a very dangerous situation because already 3 weeks this station is private from the electricity. Very dangerous situation in this area, and we can consider this is one of the pressure tools of Russian Federation in this conflict, but it has direct impact on the general situation, security situation, and public health situation in the country, because we are afraid that it could be the second Chernobyl, and it's very dangerous. I can repeat that this conference is very important for us, and we are very open to discuss this topic of health and climate processes. However, now for Ukraine there are some more important issues because of the ongoing war. But we are going to prepare the future, and of course we are ready to integrate these topics in the new strategy of the Ukrainian Red Cross Society activity, and we are going to implement the new strategy, to prepare and to implement the new strategy until 2030. And we took already some ideas, some recommendations, and we are very open for further cooperation. Thank you very much for your invitation. We are
here with a broad delegation. I would like to present, if possible, other colleagues, in particular Tatiana Yushchenko, my colleague who helped me to prepare this presentation, director of our pharma clinic, the new initiative of Ukrainian Red Cross Society. Also, Mr. Vadim Siversky, he represents here Norwegian Red Cross as a national project manager who supported us to implement different activities, and our operations director, Sergei Panasenko. Thank you very much for your attention, and we'll be ready to respond to your questions if needed. Thank you.
Thank you so much. Oh, thank you so much, Vyacheslav, for a very powerful presentation. And I think it really illustrates the complexities and how climate change really adds to the burden, and how the climate changes and how we try to adapt cannot happen in a vacuum. It happens in real time, and even if a situation is difficult, the climate is changing, and it's very hopeful that this is something that you're sort of already thinking about, and it's part of your thoughts for your plans ahead. So that's very, very promising. So thank you again, and thank you for coming. With that, we are moving on to our last presentation before we will have a panel discussion and open up for questions from the audience. So our last presenter today is Sonja Myhre, who is a senior advisor in global health at the Norwegian Institute of Public Health. And you will be sharing some of the work that you've been doing. So please, Sonja, the floor is yours.
Thank you so much, Taya. It's such a pleasure to be here, and really an honor for this invitation. I will say that this is quite an act to follow, but I think that these stories and narratives from country level are so important. And also I'm rethinking my research career and thinking maybe videos are the way to go. Extremely powerful. But anyways, so yes, it is a bit intimidating to switch gears from these very much like on the ground experiences and the work that Red Cross is doing, and now shift to the desk in Oslo of a researcher and the work that we do. But I think there are some inspiring lessons from this as well. So the title of my presentation is Building and Strengthening Climate Resilient Health Systems in Low Resource Settings, Reflections and Lessons Learned. So, actually, let me go back. Also, just to acknowledge that I'm presenting, but on behalf of 3 other co-authors, Katrina Fransdahl, Heather Ames, and Lila Papadoulou. So very much their contributions are very much part of this. What I will be sharing is the work that we had done on a report by the same name. This report was commissioned by NORAD with not much direction, and so we actually had to really think hard and reflect back on this. What I would say is quite a long and strong history of research in climate and health. But through quite a bit of background work, we landed on this idea of looking at this nexus of climate change on health systems and health system strengthening, resilience, and I think the key is actually in low resource settings. And I think this is something that that really my perspective on this really quite radically changed when I attended the Climate and Health Africa conference that was a year ago in Zimbabwe, and to see it was an extremely well-attended conference, 400 participants, and to see the challenges and the solutions that were being offered there. So in this report, I think it was important to focus specifically, knowing that climate change is very much adversely affecting the global south, where often these are low resource settings. So what are these? What are the solutions? What is happening? And so that became the focus of this research report. So let's see. So we were quite ambitious. This was a bit of something, another perhaps a regret, but we launched into this report with 6 key questions. So this was very much a matter of over-delivering. But what we were looking at were what are the key strategies and interventions of climate-resilient health systems, specifically in low-resource settings? What are the vulnerabilities of health systems? What are the opportunities and barriers? Who are the climate and health stakeholders? What is the current state of data, of indicators, of metrics? And then finally, how of these studies that we're going to look at, or the study sample, how are ethical and equity considerations either mentioned or discussed? So I'm jumping over the methods, but I have another presentation on this if you want to get more into the weeds of all of this. The methods, just very briefly, was we used a very classic scoping review methodology of Arksy and O'Malley. We were very systematic in the approach of this, and we actually culled over 7,000 records. And of those 7,000, we identified 66 studies. And the study characteristics, as you can see here, are just summarized in that we found that the years were between 2006 and 2023. And that's because the search strategy ended in 2023. Not that there wasn't research after that, of course there has been. The number of countries was, we identified studies that were coming from 30 different countries. 7 of the studies we identified were multi-country, so they were reporting on either a range of Pacific Islands or some sort of sample. And then the climate focus was we found that it was on very general things, but a hurricane, flooding, drought, heat. I mean, it was quite varied. And again, I'm not going to go into detail, but I invite you to read the report. I'm going to, in this presentation, just focus on that first key research question, where we were looking at what are the key strategies that are being reported now in the literature. And again, just to say that as a researcher, we can only go by what is been published. So this is by no means saying this is only what's been done. This is only what we can see in the literature. And by using a scoping review methods, we also are just doing sort of a scan. We're saying, like, this is what's out there. At this stage of the research, we're not able to do a systematic review. The level of the studies are not there yet. We're quite early in it. So this is sort of laying the foundation. So anyways, we decided that because this is quite a number of studies, 66, is how are we going to organize these findings when we're looking at this? And so it became very convenient, actually, and made quite a bit of sense to use the WHO building blocks of their strategies, which Claudia has already mentioned, but to categorize into these 6 categories. So that's what we were looking at when we were going through these studies. And I will say that one thing that I feel particularly proud about in this report is that I think that in reports where you're trying to say a lot of different things, a lot of times you just end up with key strategies and things sort of bubble to the top. But we made a huge effort to draw a red thread through what are, every key finding we had, we described and, we had parameters around it, but we also linked it directly to a study or several studies. And so you could see where is this key strategy coming from? What is this? So you can go to the actual study. So this is what when we organized it, we had tables where for each of these 6, we have like several page tables where you can find out exactly, look at the key strategy and then pinpoint exactly where this was coming from. So given the time frame, I just wanted to highlight like a few of the things and also sort of try to bring to light some of the findings that we had. So specifically in terms of service delivery, this is an article that was focusing on Vietnam, and it was looking specifically at like flood preparedness of primary healthcare facilities. And so in terms of service delivery, like several of the findings were in terms of resilience of infrastructure or having preparedness plans, having surge capacity. There's a lot of different things that were noted there. In fact, service delivery was the finding that we saw was sort of cutting across so many of the studies that we kind of we didn't really limit very many. This is another example just to like show you like what does this mean, like when we were looking at this study, what are the examples that you might see, and one of them would be, for example, like a hospital disaster communication plan. And then moving on, this is another example from a study that looked at Cyclone Idai in Zimbabwe. And so they were looking very specifically at the role of primary health care. And there, I think you can see how this paper was describing how when you are faced with a disaster, like what does this look like, and how do you recover from that? And so building back better, like understanding that if your facilities are harmed and destroyed by a disaster, then you find ways to build a facility that is not going to be affected or at least mitigated by that. And then looking at the surveillance and using data through I think a lot of things that were discussed were like mainstreaming climate and health into the health systems. So anyways, I won't go into too much detail there. And then finally, another category I wanted to mention, because it was such a strong theme, it came through in so many different articles, was the importance of climate and health training of health workers. That this is sort of, in these contexts, this is something that is extremely important, but even more so is the idea that that several articles talked about, in this case, like community health workers, and how these are very trusted members of community. They have local and indigenous knowledge, and so they can really play an important role when it comes to climate and health. So I think that's also something I wanted to share. And then finally, the last example I just wanted to point out was in terms of the health information pillar. There were several articles that were discussing very specifically about, like in this case, this is epidemia, which is a system that is in effect in Ethiopia, and it's linking malaria and disease surveillance and as an early warning system. And there's several others that were described in different areas. And so I think what I wanted to share here was that some of the key points that were raised in these type of articles is that data is so important to drive decisions. And so fundamentally, you need good data, but you also need a data culture. You need to imbibe that, like you use the data, you share the data. But that being said, I think that the basic challenge of having good data and using it and embedding that in like the routine health information systems is something that continues to be a challenge. So again, just taking it down to in low resource settings, just being realistic about what you're dealing with and adapting to that. So with that, I think I'll close. I've given just very few examples from the report, so I really I would recommend that you look at it. And we also have taken that report and we're waiting. We've made that into a manuscript, so we're hoping that that becomes an article as well. Thank you so much for your attention. Appreciate it.
Thank you so much, Sonia. And I mean, thank you for being here, also representing research, because that's our whole idea, that we really want to bring together both practitioners and researchers and to have this sort of platform where we can discuss across. I think that's really important, and that's the strength of having these conferences as well, that it gives us an opportunity to discuss and to have those dialogues across and really building down those silos. And with that, I would like to invite the rest of the presenters up here with me. I'm sorry, but I misplaced my program. Do we have until 1:15? Can someone confirm? Yes, thank you. That's great. Excellent. Please sit. I have lots of questions, and I have some that I've prepared as well, but I think before I start with my questions, I would like to open up to the audience, if any of you have a question first. Anyone? Yes?
I have a couple, but I'll let other people go. I only let other people go because I worked for the Red Cross Climate Center for 4 years, so I have inside information here. So I guess, yeah, I have a couple, but I'm going to start with the presentations both from Burkina Faso and Ukraine. Those were both really wonderful and powerful and interesting conversations. And I thought that it was interesting because in both of these countries, you have conflict in different ways. And the war in Ukraine was mentioned a few times, but I thought it was interesting that the overlap between climate and conflict wasn't touched on as much. And I guess I was curious for both of you how you see the overlap between climate and conflict in both of your countries, and if that's something that kind of gets integrated into the work of the Red Cross in those environments. Thanks.
Okay. Having conflicts and also climate change challenges in the same context is not an easy thing. But as we have volunteers already on the ground on the different communities, so they are built a trust with the community, and so they can just doing activities without having a lot of issue. It's clear that to have access is sometimes difficult, and also because of the health facility which has been damaged by the conflict, is also difficult. But at the end, the challenges remain the same. Allow people to have access to care. So even if we have conflicts or climate change, it's the main issue for the community. So if we train volunteers to deal with the both, have safer access to the community, and also have knowledge to share with the community, I think that it's possible to work in that context.
Yeah, maybe I will start, and my colleagues Tatiana, Vadim will add. As I have already mentioned, there are two dimensions, if you want, two levels of the situation. Emergency response, it's very easy because our activity, our approach is based on the analysis of the needs of the population. And another dimension, strategic dimension, because we have in our mind strategic vision of post-war situation, of the recovery, and of course EU alignment, EU integration process. I think there are three areas, three directions that have direct impact on Ukrainian Red Cross Society activity at this stage. Tatiana, maybe you want to add something? I will ask.
Thank you. I can add something. Actually, lots of our activities going cross-cutting and somehow touch the topic of climate change. For example, our MHPSS unit, probably the largest and the most powerful direction in the Ukrainian Red Cross that cover all Ukraine, probably all the country except the occupied territories, and also that is different levels of impact and to the people, to the beneficiaries, where we can work probably in a hospital, in the different situations. MHPSS volunteers can work in a field with the people directly, and also they are working with the specialists, with, for example, firemen or other specialists that first contact any disaster that can happen. They are influence and help them to cope with that stress, for example. And also our emergency response team made a huge impact, and we also have a statement with the governmental department of Ukraine that we are two-party agreement that we have to go peer-to-peer with them and react to solve the problem wherever it's natural or human affect disaster. So yeah, thank you.
Maybe Vadim would add.
Start dancing before I sing the song. Okay. Thank you for mentioning my name a couple of times. I do have a question to say, but first of all, thank you, Vyacheslav and Tatiana. And I believe Sergei was also mentioned, who is the Director General, and I think it's already telling from the representative way that Ukrainian Red Cross Society actually has a stake in the climate change to make things for better. Since you're here, and I'm also glad for inputs from Tatiana that let's not be modest. If we have some things that have relevance, let's mention them. And it's quite an interesting notion to mention that there are things that have been done, and I think I can speak beyond the Ukrainian Red Cross, actually, myself being Norwegian Red Cross. Some things that are happening that have relevance, have direct impact, but they are not considered as such because they're cross-cutting. And I think this is for all of us to keep in mind that there could be many things being done for the benefit of the people suffering from all these climate change things that people bring to themselves. But also not to forget this notion that actually there are things done which are not so visible, so it's also good to have this conference here now in Tallinn, where we can really share those things, especially behind the scenes of how things work from the practical perspective. And on this note, I would like to ask both panelists from Burkina Faso and Ukraine, how do you see the future of the climate change? How do you see the strategic importance of that direction being a cross-cutting subject? If you can just expand a bit more on that. Thank you.
Okay. Climate change remains now an important thematic in Burkina Faso. Maybe it's well to know that in a warm country we face heat wave, for example, but it's something which happens now. So at the Red Cross level, as I already said, we introduce climate change in the routine activities of the volunteers. So we're adapting the training package to make it more climate sensitive, because it's very important. And at the National Society, they started to develop a early action protocol on heat wave, especially, and the others hazard. And also, the Ministry of Health is really have a good commitment to address this issue in the setup. So it's something I think that in the coming years we will have a clear plan to address this issue. Even at the Ministry of Health level, or also at the National Society level. So it's very important for us. And it will be a joint collaboration, not only Red Cross and Ministry of Health, but a joint collaboration to address this issue. So I think that in the next coming years, we will have something clear, and at the ground level, we will deliver activity to prevent, but also to help community to address impact of heat wave especially. Thanks.
Vyacheslav, would you like to? No? Thank you, great. Oh, sorry, I see a hand.
Thank you very much for excellent presentations. My name is Gloria Maimela, and I'm from South Africa. Just before my question, I just want to admire, the presentation from Ukraine. I think there, wasn't a single, all of us were touched by the presentation, and to see the realities of what people are going through because of war, and it's very heartbreaking. But my question is to Sonia, that, you mentioned in your presentation that, the community health workers are at the forefront, and we should be targeting them to build climate resilient health systems. And my question to you is, often, community health workers get, told that they have to take up a whole lot of responsibilities across all the systems, whether it be HIV, and now there's also the burden of climate change and health. There have been, kind of like qualitative studies to see if community health workers would, be prepared or are in a position to be able to support awareness around climate and health, and to support resilient health systems. Thanks.
Thank you so much, Gloria. That's an excellent question, and I think there's two parts to the question that I would offer. One is just to say that I can only comment because, like, as a scoping review, you can't really just pull out recommendations because we're just sort of saying this is what we saw. But I can say that in several studies, they actually did touch on what you've just mentioned, which is that oftentimes, community health members, workers they have much to cover. But interestingly, they've mentioned that their health needs to be addressed. Like there needs to be more attention to this burden and to taking care of it. I think it was more, or in addition to that, recognizing that health workers in general, in crisis or disastrous situations, their health and mental health also needs to be addressed. And so I think our group was pleasantly surprised to see several articles at this point already discussing mental health. So that's one part of your question. The second part is that you were asking, are they prepared? Actually, I think that I'm going to go with some other work that I've been doing, but that I think that there's a study from the Netherlands that found that like 11%, this was in Ethiopia, but 11% of the health workforce was aware of the links between climate and health. So there's very much a gap there. And I think that here in this room, we have a tendency to think that this is, everybody knows. But I think this is one of the areas that is really getting a lot of attention. And I would say that, as I mentioned, there was, when you looked at the health workforce pillar, there was many different studies describing the importance and the value of training. So that is very much that's very much being discussed. I hope that answered your question. Thank you.
Okay, I would like to also ask a question and circle back to you, Claudia. I mean, as we've been hearing throughout the day today, climate change is increasingly shaping health outcomes. So I was wondering if you could elaborate a bit on how the Norwegian Red Cross is stepping up our efforts to support a strengthened and climate resilient health system, and particularly in the primary health care.
Thank you. And I think that somehow is like a summary of everything that has been said. I think from the Norwegian Red Cross, we are in a position of kind of a unique role because we work very close with the national societies in many countries across different regions. And we also have taken health and climate as our flagship, something that we really want to carry on. And that is something that we are trying to mainstream in everything that we do. From the technical support we provide from the different thematics, in our case from health, but also all the work that is doing through advocacy to health diplomacy, and also how we are able to bridge the gap between practitioners and researchers, but also policymakers. So I think this is very important because we need sometimes like a reality check. What do we do at the end of the day with all the evidence that we have? And we really putting that into practice, and how we can also tap from the other resources that we have in Norway, like for example, the Institute of Public Health. So somehow we are in a position that it could be a privilege because we can access different actors that are working in different spheres, but that everybody has the same goal, that is tackling health and climate. So basically in everything that we do, from the practicalities in supporting programs in Burkina Faso and in Ukraine, but all the way through to talk to policymakers and decision makers on how we can do this better.
Great. Any last question from the audience? I think otherwise, I mean, Vyacheslav, did you want to?
Just a short question to you, Tia, and to Claudia regarding further steps. As we can see, Norwegian Red Cross has supported a few initiatives across the world, and it's a good basis for further peer-to-peer approach. How do you plan to develop? What are your further plans in this perspective? And thank you very much for excellent moderation of this panel.
The privilege of the moderator will be to just pass the question on, but I don't know, Claudia, if you...
Since Ukraine have been so inclusive, maybe I can also present Jenny, that is actually our team lead for health and protection, and might be able to tell us something about it as well.
Hi everyone, nice to see you all. And hopefully I'm not the closing of this session. I'll leave that to the panel and the presenters. But yeah, I mean, as Claudia mentioned, health and climate is a particular strategic focus of the Norwegian Red Cross, and we have integrated across our work. So from our communications, policy and advocacy department to the department supporting directly international operations around the world. So, and we like to think we can liaise closely with lots of different actors, as Claudia mentioned, so including in research. So it's great to be here today. In terms of the future, we want to continue that, embedding it in how we support. And I think it's important to mention that in the Red Cross, we're part of a membership of the International Federation of Red Cross National Societies, so we're part of a much bigger movement and network. So a lot of work on this is also led in a global sense from the International Federation of Red Cross National Societies and also the International Committee of Red Cross. So it's important to mention those organizations in our work because we are one or three members here of a much bigger global organization. So who have also prioritized climate and climate discourse and bringing that into different aspects of our work, including linking health and climate. So, Claudia, do you want to add? No? Okay. Thank you.
Thank you so much. Yeah, I mean, I think we're wrapping up. I mean, it's been I think great presentations today and great questions from the audience. It's really nice to see that you're like engaged and staying with us until 6:15 in the afternoon after a very long day. But I mean, clearly this is a conversation that needs to continue. And I think finding ways of both sort of bridging the gap between research and practice, and also sharing knowledge, sharing best practices, and then finding ways of sharing that knowledge. there's not one easy answer to that, but definitely having spaces like this to have the conversations is a great starting point, I believe. So I think with that, I'm just going to say thank you so much to all the presentations, and thank you to the audience for spending time with us this afternoon.